Assalamu alaikum. Good evening, everybody, and welcome to the Emirates Diabetes and Endocrine Society Connect. This episode is focusing on the thyroid, and this thyroid webinar series is going on this year and will carry on for the coming year as well. We already had our first session in September 2021, and it was focusing on the abnormal thyroid function test with difficult interpretations. Today, we are focusing on hyperthyroidism. We have eminent speakers, and over the coming 1 hour and a half, we're going to focus on the management and of hyperthyroidism. With us, okay, we'll start first, just a brief regarding the outline. This session will be available on the Emirates Diabetes Society YouTube channel, and it will be later on posted on the Institute website of the Society. And by the end of this talk, we're going to answer and respond to your queries and questions. So please key in your questions, either in the chat itself here, or by sending your messages on the WhatsApp on the mobile number 056-994-4287. Just to recap, this series is CMA accredited by Dubai Health Authority. It's aiming for 1.5 CME hours to be received 14 days after this webinar. And you need to fill in feedback questionnaire to be qualified for the CME. And our first speaker is Dr. Salman Razvi. He is a senior lecturer in endocrinology at Newcastle University and a consultant endocrinologist at Queen Elizabeth Hospital. The focus of his research has been on investigating the association of thyroid function on the cardiovascular events in various populations. He is the chief investigator of several projects funded by the various statutory funding bodies as well as charities. And the focus of the talk will be management of thyrotoxicosis, how and what to do. The floor is yours, Dr. Salman.
Good evening. It's a pleasure once again to be here with you on this Emirates Diabetes and Endocrine Society meeting. And this time we'll be talking about management of thyrotoxicosis. And we've got a lot of other eminent speakers talking about various aspects of this. But what I'll be talking about today is how to diagnose and manage thyrotoxicosis in our patients. A lot of this will be bread and butter for you, not a lot of new things, but as we all know, things do change somewhat in the field of endocrinology year by year. So the global prevalence of hyperthyroidism is a bit sketchy. As you'll see on your screens, we haven't really got a lot of data for many countries in the world, including large parts of Asia, Africa, and certainly nothing for the Middle East and Canada or lots of South America. As you'll see here, more specifically, the Middle East, we haven't really got a lot of data, and we assume that most of the data that's out there from Europe or the US may be similar, but we don't really know. So one of the things that would really be useful is having information from most other parts of the world about the prevalence of thyroid disease. These are my disclosures, and let me assure you that wouldn't influence any of my views. So the common causes of thyrotoxicosis would be Graves' disease, toxic nodule, multinodular thyrotoxicosis due to multinodular goiter, thyroiditis, and medications. I'm not going to go into a lot of other stuff here because the medications are going to be covered by other speakers later. So the two forms of hyperthyroidism or thyrotoxicosis is the overt and the subclinical. So the biochemical picture is slightly different in both. In the subclinical, the TSH is low, but the free T4 would be normal. Whereas in overt hyperthyroidism, apart from the TSH being low, you would see that thyroid hormones are always elevated. You could have T3 toxicosis, which is another form of hyperthyroidism, and you could see that in various scenarios. In subclinical hyperthyroidism, most would have no symptoms and are detected on screening TSH, and if need to confirm, use in 24 radioactive iodine or technetium uptake scans would be useful. So the symptoms of hyperthyroidism, again, I'm not going to go into a lot of detail about this, can also be vague, atypical, and non-specific. But thankfully, they're a lot more specific, I suppose, than hypothyroidism. So the symptoms like palpitations, weight loss, weakness, breathlessness, which are all manifestations of, say, for example, atrial fibrillation or tachycardia, high output cardiac failure, the diarrhea, which we can get, but occasionally I've seen patients present with constipation as well. Usually the appetite is increased, but we can also get anorexia, and I'm sure we've all seen this. And we also see this thing called apathetic thyrotoxicosis, where the symptoms are very different, and it's kind of linked with depression and inactivity and lethargy, withdrawn behavior, and sometimes seen in older patients with this condition. My colleague Christine published this paper more than 10 years ago now, where they showed that older people tend to have fewer symptoms. The exact mechanism as to why this isn't clear. It could be related to reduction in beta-adrenergic receptors and so on and so forth. But I think what this tells us that we have to be a lot more careful in checking for thyroid function, because the symptoms may not be readily apparent in older people. Is making the underlying diagnosis important? Or you could argue that thyrotoxicosis is thyrotoxicosis. Why do we need to find out whether it's Graves or toxic multinodular goiter or thyroiditis? Why don't we just manage it? I'm sure we all agree that it's really critical that we make the diagnosis of what is causing the thyrotoxicosis, because it helps to individualize treatment. You wouldn't treat Graves' disease the same as you treat a toxic nodule or thyroiditis for that matter. It also helps to predict risk of future risk of relapse. Making a diagnosis may be cost effective in terms of how we manage patients and how we arrange for their follow-up. For certain conditions that may run in families, it may help other family members of the same household or beyond. And particularly in pregnancy, it's very important that we know what's causing this. So if you come to Graves' disease first, this is the most common cause of persistent thyrotoxicosis. And in most populations, and again, I stress we haven't really got a lot of data for the Middle East yet, but in other parts of the world for where we do have the data, we probably see about 20 to 30 cases for 100,000 population every year. So if it's similar prevalence in the UAE with a population of a few million, you'd expect to see 300 to 600 patients at least in a year. Approximately 3% of women and half or 1% of men will develop Graves' disease during their lifetime. So it's not that uncommon. An autoimmune disorder caused by stimulating antibodies to the TSH receptor is the mechanism that causes Graves' disease. It's one of the few conditions where the autoimmune system actually stimulates and enlarges the target organ. The peak incidence occurs between the ages of 30 to 60, but it's important to remember that nearly all ages can be affected. I've seen people at the age of 90 years plus being diagnosed with Graves' disease. The symptoms can affect nearly every organ, and we've talked about some of these before: the goiter, the eyes that can be affected, the tachycardia or the other arrhythmias, the sweating, the tremors, the diarrhea, the fatigue, increase in appetite associated with weight loss, and so on. These are all quite characteristic of the thyrotoxicosis and also of Graves' disease. And specifically so because levels tend to be much higher usually in people with Graves' disease than with other causes. So how do we diagnose? Look, clinically, anyone presenting with a diffuse goiter, but the problem is about 50% of patients will have a palpable diffuse goiter on examination. So the other 50% may not. So that makes it slightly more challenging. Orbitopathy is roughly 1 in 3 patients to some degree or the other. Thankfully, severe orbitopathy is much rarer, but any degree of orbitopathy, 1 in 3 people will be affected, depending on how hard and how long we look. But the most sensitive and specific biochemical marker is measuring of the TSH receptor antibody, or TRAB for short, which is seen in about 95% of most available commercial immunoassays. The radioactive iodine or technetium-99 uptake scan is another way of diagnosing this. But keep in mind that diffuse uptake is seen in 90%, but about 10% of up to 10% of patients with Graves' disease can have patchy uptake on their tracer. And it's usually seen in older people who might have underlying nodular thyroid on top of which they develop their Graves' disease. If we do a uptake scan and find non-uniform uptake, it's likely to be a toxic multinodular goiter, but keep in mind that around 10% of patients with Graves' disease can have a non-uniform uptake, depending on their underlying thyroid. Positive TP antibodies are not very sensitive to diagnose Graves' disease and are only positive in about 3 to 4 out of every 4 or 5 patients with Graves' disease, which means there will be some that will be missed if this alone is used as a marker of autoimmunity. The other thing we need to think about is the TRABs themselves. And we published this a few years ago where we looked at the impact of age on TRABs. And what you'll see here is that the TRABs at diagnosis were related to the free T4 as well, which is what you'd expect: high the TRAB, high the free T4. But what was interesting is that it depends on the age. So in younger patients, 17 to say 40 years of age, as high as the TRAB went, the T4 went higher. But in older age groups, above the age of 55, after about the level of 10, there was a flat response. So the higher TRAB didn't really seem to stimulate the thyroid more than what it could. So it was almost like the thyroid wouldn't respond to much higher TRAB. Now, we don't understand the mechanism, whether it's the thyroid that becomes less responsive or whether the TRABs themselves might be not as stimulatory or might have more blocking compared to stimulatory antibodies. We don't really understand that mechanism more, but this is something to keep in mind, that higher TRABs don't necessarily translate into higher T4 or T3 levels, also for that matter, in older people. The relapse risk is also related to age. So as you'll see here, is that we know that TRABs at diagnosis are related to the risk of relapse, and higher the TRABs, higher the risk of relapse, as you'll see here at the top. But you'll see again that TRABs are not such a good predictor of risk of relapse in older people. And so in younger people, it's kind of a linear relationship. Higher the TRAbs, higher the risk of relapse. In middle-aged people, it's slightly less so, but in older people, above the age of 57, it's a flat line. So whether your TRAbs at diagnosis are 5 or they are 30, the risk of relapse isn't as well predicted. So using TRAbs is all well and good, but we have to keep in mind certain limitations, particularly around age, and the fact that most commercial TRAb assays will not differentiate between stimulatory versus blocking antibody. So what we can conclude from this specific part is age does have an influence on TRAbs and the effect on thyroid function and risk of relapse. And TRAbs at diagnosis have better predictive value in younger patients with Graves' disease, but not so much in older patients. This is from 6 years ago, but nothing has changed considerably since then. David Cooper and Birch published this in JAMA. So the primary treatments for Graves' disease still remain the same. Antithyroid drugs. Potassium iodide isn't really used a lot, but can be a temporary stopgap measure until more definitive forms of treatment are utilized. Radioactive iodine therapy and surgery. So I'll refer you to that paper. I'm not going to go into the details of this. There are pros and cons of each approach. Antithyroid drugs, they are relatively straightforward. The risk of side effects is low, although in some instances may be severe and potentially even life-threatening, such as hepatotoxicity or agranulocytosis, but it's relatively low, the risk of these side effects. Radioactive iodine is useful because we know what the outcome would be in the vast majority of patients and tends to be cost effective, and it's certainly known to be the least expensive of these options. Surgery is probably the most expensive in terms of the amount of time it takes up in hospital and risk of side effects and so on, and the need for monitoring of other things apart from thyroid hormones such as calcium and recurrent laryngeal nerve damage. So if you decide to treat with antithyroid drugs, how long would we treat for? Most clinicians would agree that we should treat for at least 12 to 18 months. If relapse occurs subsequent to that, then radioactive iodine should be considered. There is a risk of agranulocytosis, carbimazole or methimazole. The risk is slightly higher than with propylthiouracil, and in the literature, risk of 3 per 1,000 is quoted, but my personal experience is that this risk tends to be dose dependent, and in patients where you use a lower dose, such as 5 or 10 milligrams of carbimazole, or even 20 milligrams, the risk is considerably lower, and 40 milligrams of carbimazole, the risk is higher and can approach 3 to 4 in 1,000. The other thing to keep in mind is that the most likely time point at which agranulocytosis can occur is about the 3 months after starting antithyroid drug. So if somebody, although it can happen at any time, but if somebody presents immediately the next day, it's very unlikely that it's agranulocytosis. It's not an allergy. The risk of severe hepatotoxicity is much higher with propylthiouracil than it is with methimazole or carbimazole, and some would argue that it's about risk of severe needing hepatic transplant, about 1 in 20,000 patients that are treated. There is some evidence that antithyroid drugs can be used until TRAb levels are low, and that might modulate risk. We'll talk about that in a little bit more detail in just a few slides. In fact, now, this paper from Edinburgh looked at TRAb levels at diagnosis towards the end of the thionamide treatment, so that's antithyroid drug treatment, and whether it would predict the risk of relapse of Graves' disease. And what you'll see here at diagnosis, so the y-axis, the cumulative remission, so higher the line, the lower the risk of relapse, or higher the chance of remission. So as you'll see here, when TRAbs are less than 5 at diagnosis, the risk of remission or the chance of remission are much higher, about 50%. When TRAbs are high at baseline, so more than 12, the risk of relapse is much higher. So if you take this as 20%, this is a 20% chances of staying in remission, which means 80% risk of relapse, whereas if the TRAb is less than 5 at diagnosis, there's a 50% risk of relapse. Now, on the right-hand side, this is the TRAb levels at cessation of anti-thyroid drugs. And what we see here is that this is also a very good marker of risk of relapse. So in those patients where the TRAbs are completely undetectable or very low, so either less than 0.9 or up to 1.5, the risk of relapse is much lower than where people's TRAb levels are greater than 1.5, where the risk of relapse approaches the 80% mark. So again, tells you that potentially we could monitor people's TRAb levels and only consider stopping treatment once the TRAb levels are negative. Now, it may not necessarily mean that we treat for more than 12 to 18 months. It could also mean, but this has still to be evaluated, we might be able to treat for less than 12 months as well. If some of these TRAbs become undetectable in 8 months' time, you could consider stopping therapy at that point. But let me stress that this hasn't really been tested in a randomized controlled trial fashion, but it makes biological sense. Now, the other question, and a lot of people ask this, including a NICE here in the UK have asked this question, wouldn't radioactive iodine be better? The reasons for that would be it's effective. Most patients we know would have a predictable outcome, which would be, 90% would be hypothyroid. It's cost effective. Patients, once they're hypothyroid, can be discharged on levothyroxine back to their usual doctor, so they don't need to attend hospital or specialist clinics, which are considerably more expensive. But the downside is it may not be suitable for some groups, such as women planning pregnancy, those who have got caring responsibilities, say young children or older relatives where they have more physical contact, patients with active Graves' orbitopathy. It's an issue whether you do provide steroid cover or not, and so on. And sticking with this theme of Graves' orbitopathy, it could exacerbate or trigger Graves' orbitopathy in some patients, particularly those whose hypothyroidism has been detected. So hypothyroidism after radioactive iodine, if not treated, Graves' disease is a risk that needs to be kept in mind. Smokers, particularly because of the TRAb levels, tend to have higher risk of developing Graves' orbitopathy. So just have to keep that in mind. And also this fact that there's a transient worsening of thyroid function, about 10% of patients after radioactive iodine due to release of thyroid tissue and subsequent increase in TRAb levels. And again, this could be an issue in older patients, and therefore some people argue or advocate treating with block and replacement post-radioactive iodine for 6 weeks or 3 months to try and mitigate against this risk. So what about risk of mortality and cardiovascular events in Graves' disease patients and in relation to treatment modalities? This is a paper of a large database from Wales that one of my colleagues from Cardiff have published in 2019. As you'll see here, that patients tend to have higher risk of mortality as well as cardiovascular events compared to euthyroid population or the background population. The risk was certainly higher in the people treated with anti-thyroid drugs as well, and it wasn't high in the mortality in patients treated with radioactive iodine who were then subsequently euthyroid and levothyroxine. And it was borderline for cardiovascular events, but also high for people with radioactive iodine treatment who continue to have hyperthyroidism subsequently. So I suspect what this is telling us is that Regardless of the method of treatment, early and effective control of hyperthyroidism among patients with Graves' disease should be the goal of treatment, and rapid and sustained control should be prioritized in the management. And early definitive treatment with radioactive iodine should be offered to patients who, in your consideration, or in all likelihood, are unlikely to achieve remission with antithyroid drugs alone. So people who smoke, people who have higher TRAb levels at diagnosis, who are not achieving good control with the antithyroid drugs, plus all the usual other large goiters, presence of eye disease, which is inactive and so on, should be the kind of considerations that are kept in mind. What about Graves' orbitopathy? I'm not going to talk a lot about this. Usually mild and transient in most patients, thankfully, and can be managed by lubricants and taking effective and good care of the eyes. Severe disease, which shows active orbitopathy, may and should, in my opinion, require multidisciplinary team approach. It's not just endocrinologists who deal with it. You need ophthalmologists, and you need opticians and so on. So that is useful. IV pulse steroid therapy and increasingly plasma cell depletion using MABs such as rituximab may be useful in people who do not respond or who might have DON or dysthyroid optic neuropathy related to Graves. And also, I'm not going to dwell on this too much, but selenium has been shown in adequately designed trials to be of effect of benefit in moderately active Graves' orbitopathy. I'll briefly mention this here. I know another colleague is going to talk about the treatment of eye disease, so I'm not going to dwell on it too much, but let me just briefly mention teprutimab, which has been used recently and is available in the US, but the cost is eye-watering for this. And I'm not going to dwell too much on the design, but it did show a good response. Now, a brief mention about other things. The biochemical picture of Graves' disease can be mimicked by people on high doses of biotin, and in assays that use biotin as part of measuring TSH, free T4, free T3, as well as TRAb. So a lot of supplements these days available over the counter do contain biotin. The stated benefits that are claimed is that it helps with fertility and increasing terms of reproduction, effect on hair and nails, and so on. So a lot of shampoos contain biotin, a lot of multivitamin supplements contain biotin. But usually high doses are present, and say this supplement here contains 150 micrograms of biotin, which is more than 3 times the recommended daily allowance. And it is important to remember that this can interfere with some assays that utilize biotin as part of the immunoassay. And it can therefore lead to a picture that is similar to Graves' disease, where the TSH is low, free T4 is high, free T3 is also high, and TBI is also elevated. I must also stress that these assay manufacturers are aware, as we are, that this is an issue, and they are working to try and come up with solutions. And some laboratories have already started moving to newer assays that are less affected by biotin, but it might still be an issue in some labs. So it's just important to be aware of this. Every patient, particularly those with very little symptoms of thyrotoxicosis, but have a biochemical picture to this. The solution is very simple. If they're on biotin, and you'd be surprised how many people do take biotin, is just to ask them to stop it for a couple of days and then recheck the blood test. It's got a short half-life, so it'll be out of the system by then. And occasionally you are surprised to see that thyroid function is completely normal 2 days later. The other thing that is also important to remember is neutropenia. Mild neutropenia sometimes is thought to be due to antithyroid drugs. But importantly, the thyrotoxicosis itself can cause a mild neutropenia, and therefore treatment would be to treat the overactive thyroid rather than go with other forms of therapy. So we looked at this before. High levels of free T3 at diagnosis were related to lower levels of neutrophils. The mechanism isn't clear. It could be related to the effects, toxic effects of thyroid hormones on the bone marrow, because you see this picture with other cells, including red cells and platelets as well, to an extent. But what's important is that once the hyperthyroidism is treated, neutrophil levels do increase. I've had some patients that actually were admitted to hospital 2 days after antithyroid drug was started because they were noted to have a neutropenia, which was incorrectly thought to be due to the antithyroid drug, and the antithyroid drug was stopped and so on. But we restarted the antithyroid drugs, and once the thyroid hormones improved, their white cell counts improved as well. So the treatment, so the thing to remember is that a mild neutropenia is not agranulocytosis. Agranulocytosis is neutrophil levels less than 0.5. I'm not going to dwell too much on this. What about subclinical hyperthyroidism? I'm not going to, again, go too much into details here, but subclinical hyperthyroidism has been associated with increased risk of total mortality, coronary heart disease mortality, coronary heart disease events, and atrial fibrillation. The data is rather strong for atrial fibrillation, and therefore treatment should be considered in people at high risk of developing atrial fibrillation, and particularly people with more severe forms of subclinical hyper, such as those with suppressed TSH and older individuals. What about subclinical hyperthyroidism due to Graves? We looked at this a few years ago, 5 years ago to be precise, and what we found is that it follows the rule of thirds. So if you have somebody with subclinical hyperthyroidism due to Graves' disease, then a third of them will remain subclinical hyper, a third of them will progress to overt hyperthyroidism, and a third will normalize. The risk is dependent on two main factors, the risk of progression. One is older people, so older people are more likely to progress. And secondly, those with positive TPO antibodies are more likely to progress to overt hyperthyroidism. So just keep that in mind. So what about moving on to nodular thyroid? The diagnosis tends to be made both by the fact that they are usually TRAB negative, and if you do an uptake scan, either using radioactive iodine or technetium, it's got this typical picture. So on the right-hand side, you'll see a toxic multinodular thyroid, and on the left-hand side, you'll see a solitary toxic nodule, usually seen in older people compared to Graves. But again, I stress that age by itself shouldn't be the deciding factor as to the underlying etiology. Thyroid hormones tend to be not as high as Graves' disease, but can be very high occasionally. And in these patients, radioactive iodine is most effective in achieving either euthyroidism or hypothyroidism, and is also cost effective in these patients. Long-term antithyroid drug may be considered if radioactive iodine cannot be administered, or if surgery is contraindicated in the group of patients. So what about thyroiditis? I'm not going to, again, dwell too much on this. It tends to be self-limiting, and the diagnosis is based on the two typical factors of the fact that they are TRAB negative, and on uptake scanning, there's hardly any uptake, as you see here on the right-hand side of the screen. Can be triggered by viral infections. And the other thing to keep in mind, again, as part of my usual practice, is to look at, have they had any contrast media administered in the previous 3 to 6 months? And occasionally we do find this, and with the increasing use of contrast media and the contrast media is typical in say CT scans with contrast, or angiography that uses contrast. It has 300 to 1,000% more iodine than the recommended daily allowance, and that can be a common cause of causing thyroiditis. Thyroiditis might not require any treatment, but beta blockers may be useful if the patient is symptomatic. Steroids may be useful if the thyroiditis and the is persistent, or if there is associated pain. there is a long-term risk of hypothyroidism, mostly people who are TPO antibody positive. So again, I think it's important that we try and individualize our approach to patients with thyrotoxicosis. There's no one-size-fits-all for most of these. And to conclude this talk, blood tests can help to make a diagnosis, but are not diagnostic by themselves. And by that, I mean the T4, T3, and the TRAbs, and the TPO antibodies. So clinical examination, the family history, and so on should be also used. We should always be treating the patient and not the numbers. And this is true for everything, not just thyrotoxicosis. Discuss with our biochemistry colleague if something doesn't fit. And we always keep thinking about Graves' disease, although it's common, but I think we need to keep our thinking hat on when we see all of our patients. And I suppose that's the reason why we chose our specialty in the first place. So thank you for your attention, and I will be happy to take questions at the end of this session. Thank you.
Many thanks, Dr. Salman Razvi, for interesting talk. And as mentioned, please spare your questions until the end of the webinar. We're going to respond to all queries and questions. We're moving on to the second talk, which is entitled Drug-Induced Hyperthyroidism, to be delivered by Dr. Christine Bollard, a professor of endocrinology at the University of Birmingham, a consultant endocrinologist at the University of Hospitals Birmingham. Her clinical research interests include the management of thyroid dysfunctions, nodules, and endocrine disorder in pregnancy. She is the clinical lead for the NICE guidelines on thyroid diseases and the National Consensus Statement on the Management of Thyroid Cancer, and the Royal College of Obstetric and Gynecologists Green Top Guidelines for the Management of Thyroid Diseases in Pregnancy. Welcome, Professor Christian, and the floor is yours.
I don't know why I can't share my screen. I can't see my PowerPoint file.
Probably you need to open it first in the desktop and then you share it. Yes.
Yeah, it's open. Oh, there we are. Can I just check that you can see that and that you can hear me?
Yeah, very much, very clear.
Okay, so apologies for that. Thank you to the organizers for asking me to speak here on drug-induced hyperthyroidism. I have no conflicts of interest to report. So just as an overview, I have illustrated this with a number of clinical cases. And of course, there are a multitude of drugs that are associated with hyperthyroidism, but I have focused on the ones that I certainly come across most in my clinical practice, and that's amiodarone, alemtuzumab, immune checkpoint inhibitors, and then I also have a case of factitious thyrotoxicosis. So the first case to illustrate is a 25-year-old male who presents with palpitation, tremor, and weight loss. He has complex congenital heart disease and an implantable defibrillator. He has paroxysmal atrial fibrillation, which is resistant to electrical cardioversion, and he's anticoagulated and on amiodarone 200 milligrams daily. So he presents with signs of thyrotoxicosis. He has a tremor, a pulse of 96, a normal blood pressure. His thyroid is not enlarged. He has no palpable thyroid nodules, and there is no thyroid bruit. And you can see that his thyroid function 3 months ago was normal, whereas today he has an undetectable serum TSH a significantly raised free T4 and a T3 that is much less raised. So amiodarone is a class 3 antiarrhythmic drug used for atrial and ventricular arrhythmias. And amiodarone-induced thyroid disorders are reported in up to 1 in 4 people who take this drug. You can have a variety of thyroid problems, but amiodarone-induced hypothyroidism, which is not what we're focusing on here, usually occurs in the first 3 months after treatment and is more common in women, in iodine-replete areas, and in patients who have underlying autoimmune thyroiditis. What we're talking about here is amiodarone-induced thyrotoxicosis, which is less common than the hypothyroidism and occurs in 5 to 10% of cases of patients who have started on amiodarone. This is more common in iodine-deficient areas, and it is clear that there is no relationship to the dose of amiodarone. This is not a dose-related effect. So amiodarone has a multitude of effects on the thyroid gland, but they can broadly be divided into iodine-related mechanisms and mechanisms not related to iodine due to the toxicity of the drug itself and to effects on the iodinases. So in amiodarone-induced thyrotoxicosis, certainly in the first type, the main effect that we see is a Jod-Basedow effect, which results in an excess or comes about by an excess of iodine substrate resulting in hyperthyroidism. In amiodarone-induced hypothyroidism, the effects that we see are the Wolff-Chaikoff effect, which is an inhibition of iodine organification. And if there is an escape effect, then the thyroid function generally returns back to normal. But if there's a failure to escape, then often hypothyroidism ensues. There are also cytotoxic effects from amiodarone, and that results in a destructive thyroiditis, and this is type 2. So it's type 1 and type 2 amiodarone-induced thyrotoxicosis that I will be focusing on. You have to be aware that amiodarone inhibits the iodinase 2 enzymes and therefore decreases the T4 to T3 conversion. And as you could see in the case that I illustrated, the free T4 was actually quite significantly raised, whereas the T3 was only mildly raised. And furthermore, there is reduced hormone action by inhibition of binding of T3 to its nuclear receptor. So most patients who are on amiodarone will have to some degree, at least initially, some thyroid function abnormalities. That does not mean that they have amiodarone-induced thyroid dysfunction. So often initially, thyrotropin or TSH will increase, T4 will also increase, and T3 will decrease, mainly by inhibition of the iodinase enzymes. Of course, reverse T3 is not something that we generally use in clinical practice. With longer-term therapy, often thyrotropin is normal. T4 can be slightly increased, as can be, and T3 will be slightly decreased. So in order to diagnose amiodarone-induced thyrotoxicosis, I think you should have a thyrotropin that's undetectable and a free T4 and free T3 that are above the normal range. So how do we distinguish between the two types? And this is important because our therapies depend on which type of amiodarone-induced thyrotoxicosis the patient has. So in type 1, which is the effect of iodine, this often occurs in patients who have underlying thyroid abnormalities. Thyroid antibodies are often present, and this is not something that will spontaneously resolve or that is associated with subsequent hypothyroidism. The best way to distinguish between type 1 and type 2 is doing a color flow Doppler ultrasonography, which in type 1 will show increased vascularity and in type 2 will show absent hypervascularity. So the type 2 is caused by the direct cytotoxic effects of amiodarone, usually occurs in patients who don't have underlying thyroid abnormalities. So therefore, when you check antibodies, they are usually absent. You can also look at thyroidal radioiodine uptake, which will be suppressed in type 2 and which can be low or even increased in patients with type 1 amiodarone-induced thyrotoxicosis. So the treatment of type 1 is generally with antithyroid drugs, and of type 2 is with oral glucocorticoids. So going back to our case then, we checked the TSH receptor antibodies, which were negative. TPO antibodies were also negative. And you can see that there was no, that on ultrasound, this is not what I'm showing here, on ultrasound there was no increased vascularity And you can see that there was very little uptake. So this patient had type 2 amiodarone-induced thyrotoxicosis, and we started him on steroids. But what I usually do in patients with type 2 is that I also add in anti-thyroid drugs. Because as I said, type 1 is usually treated with anti-thyroid drugs, metimazole or carbimazole, or propylthiouracil in rarer cases, whereas type 2 generally is treated with steroids. However, often patients have a mixed type, and combination of metimazole and prednisolone often results in good outcomes. So as I said, you distinguish between them by looking at underlying thyroid pathology, but a color Doppler sonography really is the best way to distinguish between them. So in type 1, if they improve with metimazole, then sometimes you can discontinue them. It may be that these patients require subsequent treatment, but very much, it's not advisable, for example, to give radioactive iodine in a patient who's still on amiodarone, because this will be ineffective. And I think you should leave at least a lag of 12 months before considering giving radioactive iodine. So should we discontinue amiodarone in patients who develop AIT? Well, there are a number of advantages and disadvantages to this. Of course, patients who are on amiodarone are on it for a reason. Often they have life-threatening arrhythmias, and there isn't another suitable antiarrhythmic drug. It also has cardioprotective properties. And a further disadvantage is that even when you stop amiodarone, it stays around, as I've said, for nearly a year. And therefore, stopping it doesn't immediately result in a good effect. Of course, the advantage if you stop it is that you no longer expose the patient to this offending drug. You have a greater chance of achieving euthyroidism. If you continue it in type 2, then that's associated with a delayed restoration of euthyroidism. What I usually do is I liaise with the cardiologist. I must say in most cases, they feel that amiodarone cannot be discontinued, and we continue it, but treat the patient according to the type of amiodarone-induced thyrotoxicosis they have. An I-123 scan is useful to determine uptake, especially, so if a patient has, for example, had type 1 amiodarone-induced thyrotoxicosis, they're considering having radioactive iodine. So if they've stopped amiodarone for 12 months, then I do this uptake scan. If there is uptake in the thyroid gland, then I will recommend that we treat with radioactive iodine. I have also had a number of patients who have had previous amiodarone-induced thyrotoxicosis, where the cardiologist says, look, we would really like to restart this, they're euthyroid at this point. And in some of these patients, I have recommended radioactive iodine to ablate the thyroid gland or a prophylactic thyroidectomy. Moving on to the second case, this is a 34-year-old female patient who has relapsing remitting multiple sclerosis. She has had 2 courses of Lemtrada or alemtuzumab. The last course was 18 months ago. She was started on metimazole 9 months ago, and she was referred to me when she was 14 weeks pregnant on a high dose of propylthiouracil. You can see she's thyrotoxic with a regular pulse, but tachycardic. She's tremulous and she has sweaty palms. She has a moderately enlarged diffuse goiter, and she has signs of ophthalmopathy with a clinical activity score of 3. When we look at her thyroid function test, you can see that at diagnosis of Graves' disease, she had good going thyrotoxicosis with a significantly raised 3T3 and 3T4 and very raised TSH receptor antibodies. And you can see that despite treating her with antithyroid drugs, she really hasn't responded. So here we are with a 14-week pregnant lady with severe drug-induced Graves' disease, who is where we have to come to a management plan. So the question is, do we continue propylthiouracil? Do we change back to metimazole, bearing in mind that she's previously not responded to this, or do we give her a thyroidectomy? So alemtuzumab is a pan-lymphocyte depleting drug, and subsequent recovery of immune cell numbers is what results in these immune reactions. We see a similar effect with patients who undergo treatment with HAERT for HIV. And most commonly, alemtuzumab causes Graves' disease in about 30 to 40%. It is less likely that this causes hypothyroidism or thyroiditis. And TSH receptor antibodies play a major role here. It is different from spontaneous thyroid dysfunction, which my colleague Salman has already spoken about. So this often has a fluctuating course in up to 20% due to coexistence of stimulating and blocking antibodies. So often you have episodes of hyper and hypothyroidism alternating. And even in patients who have hypothyroidism, TSH receptor antibodies are often raised, and there will be largely blocking antibodies in that case. So we actually have some European guidelines on how we should manage and monitor these patients. So what is recommended is that you measure a serum TSH at baseline, and that you then do 3 monthly thyroid function tests for the 4 years after alemtuzumab administration. It is not recommended that before you start or after you stop it, that you routinely measure thyroid antibodies, perform a thyroid ultrasound, or do isotope scanning, but we should also alert patients regarding symptoms and signs of hyperthyroidism and tell them to seek medical advice when this is needed. In patients who are euthyroid, it is not necessary to routinely measure antibodies, nor to do any scanning. If patients become or develop biochemical thyrotoxicosis after the treatment, it is recommended that you measure TRAb and that you follow general guidance to consider a technetium scan or thyroid ultrasound with Doppler flow if this is negative. If thyroid dysfunction persists for more than 3 months or in high-risk patients, it is recommended that you start treatment with anti-thyroid drugs. And if the patients, because as this patient illustrated, she also has Graves' orbitopathy, that should be managed in a multidisciplinary team with ophthalmologists. If patients develop alemtuzumab-induced thyroiditis, then generally, like with most cases of thyroiditis, this is managed conservatively. And again, this is taken from the guidelines. So if a patient is on alemtuzumab and develops signs of thyrotoxicosis, you measure serum TSH, and you do that at least twice. If it's suppressed, then you measure circulating thyroid hormone and TSH receptor antibodies. If they are positive, then that is a diagnosis of Graves' disease. And after 3 months, you commence anti-thyroid drugs, and generally this will be continued, like for most cases of Graves' disease, for 12 to 18 months, and then give them a trial of it, but monitor for relapse. If anti-thyroid drugs are not tolerated or patients choose to have different treatments, then you can consider radioactive iodine or total thyroidectomy. If TRAb is negative, then I would suggest that we do a thyroid scintigraphy scan. If this shows increased bilateral uptake, then this is Graves' disease, which is TRAb negative, and you follow this pathway. If there is evidence of toxic nodular disease, then that should be treated as per local guidelines. So this is a study from my friend and colleague Carla Moran, who looked at 52 patients in the UK who developed alemtuzumab-induced Graves' disease. You can see that many of these patients were initially treated with a block and replace regimen. A smaller group was treated with titration, and 3 patients immediately went to radioactive iodine. But you can see that in the longer term management, quite a few patients required radioactive iodine. And certainly in my experience, alemtuzumab-induced Graves' disease can be quite resistant, and many of these patients do require a definitive treatment option, be that in the form of radioactive iodine or via thyroidectomy. You can see that about 8 patients did require long-term anti-thyroid drugs. Moving on to the next case then, so and changing tack a little bit here. So this is a 52-year-old male patient who has been diagnosed with a malignant melanoma 2 years ago. He developed liver metastasis 4 months ago, and he's on combination therapy with 2 immune checkpoint inhibitors. He presents with increasing fatigue. There is not much to find on examination, so he has a normal regular pulse, a normal blood pressure, and no thyroid signs. You can see that his thyroid function was normal 3 months ago, but now it has become abnormal with a significantly raised free T4, a significantly raised free T3, an undetectable TSH, and TSH receptor antibodies are negative. So these drugs are used increasingly for a number of conditions, and there are 2 main classes of these drugs. So there are CTLA-4 inhibitors. So this is cytotoxic T lymphocyte antigen inhibitors. And this cartoon here illustrates what this drug does. So you have CTLA-4 on T cells that interact with antigen presenting cells in the tumor environment. And the drug essentially blocks this interaction and thereby changes the immune status of the tumor and results in positive outcomes. And the main offending drug here is ipilimumab. And then you have a whole range of PD-1, PD-L1 inhibitors. So this is programmed cell death 1 or programmed cell death ligand 1 inhibitors. And what this results in is a modulation of immune response. You can see here in a number of cancers, what you need is an interaction between the cancer cell and T lymphocytes via this programmed cell death 1 protein or its ligand. And the drugs essentially interfere with this, changing the immune environment of the tumor and resulting in positive outcomes. So these drugs have a whole host of side effects, but what we're concentrated on here are the endocrine side effects. And so they affect the thyroid, they can affect the adrenal gland, they can affect the hypophysis, and they can also result in pancreatic effects and result in diabetes. So thyrotoxicosis occurs in about 5 to 20% of patients treated with CTLA-4 inhibitors and in 30 to 40% of those treated with PD-1 inhibitors. This usually peaks in the first 6 months following treatment, and in most cases, this is a thyroiditis which is self-limiting and transient. However, it's often a destructive thyroiditis and patients may end up on long-term levothyroxine. So we don't have that many data on how these patients behave, but this was a nice study published this year, looking at 20 patients who were treated with these PD-1 inhibitors. 5 of these patients, so 20 patients developed thyrotoxicosis, and 5 of them had a positive uptake on a technetium scan and were TRAb negative. And you can see when you look at the levels of free T4 and free T3, so free T4 on the left, free T3 on the right, this was higher, free T4 and free T3 were higher in patients who presented with a goiter and in patients who presented with a positive technetium scan. And this was lower and normalized over time much more quickly in patients who did not have a goiter, so had a normal thyroid volume or had a negative scintigraphy scan. And what this paper proposes is that maybe similar to what we see in amiodarone-induced thyrotoxicosis, you have a type 1 and a type 2 reaction, because only 5 of these patients remained hyperthyroid. Anti-thyroid drugs were given to 11 patients, so 5 of the patients where thyrotoxicosis was persistent, and also in 6 of the patients who did not have a positive uptake on a scintigraphy scan, and you can see that they are most effective in those patients who have a positive scintigraphy scan. So patients who have evidence of a form of Graves' disease, that's where anti-thyroid drugs are effective, and as expected in patients who have a thyroiditis type form of the drug-induced effects, anti-thyroid drugs are not effective. So also important, the risk of hypothyroidism was higher with larger thyroid volumes. So whilst most guidelines do not recommend routinely that we do an ultrasound or an isotope scan in these patients, it may actually help us predict what the course is going to be. This is a further study looking at 243 patients who were treated with immune checkpoint inhibitors, and TRAb positivity was found in only 2% of these patients. So this was a total of 5 patients. And you can see that only in 2 of these patients, this was true hyperthyroidism that followed a long course requiring anti-thyroid drugs, whereas in the 3 other patients, actually they reverted quite quickly to hypothyroidism, so they had a destructive thyroiditis and ended up on levothyroxine. 1 patient unfortunately died before the follow-up period was completed. So these are the guidelines from the Society for Endocrinology on what to do when you have thyroid function abnormalities in patients who take these immune checkpoint inhibitors. What we're focusing on here, of course, is when serum TSH is below the reference range, so where we have thyrotoxicosis. So if free T4 is above normal, this is hyperthyroidism, and like I said, it's probably secondary to thyroiditis. Patients may need symptomatic treatment with beta blockers, but if there are persistent symptoms, or certainly if TRAb is raised, then they may actually require anti-thyroid drugs. If they have a low TSH and a low T4, then think that maybe this could be hyperpituitarism, and therefore a 9 a.m. cortisol check is important. Bear in mind that you can get funny thyroid function tests with a normal TSH and abnormal circulating thyroid hormones, and that of course they can also induce a form of hypothyroidism, either subclinical or primary hypothyroidism, but that is not the focus of what we're talking about here. And then my final case is of a 36-year-old veterinary nurse who presents with palpitation, tremor, weight loss, and heat intolerance. She's been taking metimazole, 20 milligrams daily, and propranolol for 9 months. She is quite thyrotoxic. She has a pulse of 110 in a regular rhythm, a normal blood pressure, and a low BMI. She does not have thyroid enlargement, no palpable thyroid nodules, and no bruit, and there are no signs of ophthalmopathy. You can see that she was thyrotoxic 9 months ago with an undetectable TSH and raised 3T3 and 3T4. And today, again, she is quite thyrotoxic with TSH receptor antibodies that are not detected. At diagnosis, she had a technetium scan, which did not show any uptake of radiotracer. And I have asked for a thyroid ultrasound, which shows a normal sized thyroid gland with no nodules and no increased vascularity, as well as an I123 scan, where you can see that after 24 hours, there is no uptake in the thyroid gland. And so this is a case of factitious thyrotoxicosis. So thyroid hormones can be abused either intentionally or unintentionally. So some patients may wish to get weight loss, improved energy. Some patients overdose on anti-thyroid drugs deliberately. Some physicians may prescribe it in a wrong indication. Patients may specifically choose to have excess dosing, and sometimes patients can take supplements that contain thyroid hormones. And again, that can be intentional or unintentional. It is relatively common in the pediatric world, where sometimes too high a dose is given. Exposure to thyroid, so to foodstuffs that contain thyroid hormones, and so what's been described as hamburger thyrotoxicosis, so where the beef that was used in these hamburgers, the cattle were actually treated with thyroid hormones, and then there can be pharmacy errors. And then a number of outdated situations are that this was thought to potentially be useful in premenstrual syndrome, for lipid control, and in the SICU thyroid syndrome, although this is now very rarely used. And it remains controversial whether the use of thyroid hormones is useful in patients who have treatment-resistant depression. So what do we find in patients who ingest thyroid hormones when this is not required? Well, it very much depends on whether they take levothyroxine or liothyronine. In most cases, TSH will be undetectable, and then whether T3 and T4 are raised very much depends on what patients are taking. Importantly, thyroglobulin is usually reduced, and when you check for an ESR to see if this is a thyroiditis, then this will often be normal. Radioiodine uptake will be reduced, as was illustrated by our case. And again, the case that was described in this paper here, you can see that there is no uptake of radioiodine in the thyroid bed. So it's really difficult, or can be really difficult, to distinguish between these situations, because thyroid function will probably be pretty similar with an undetectable serum TSH in factitious thyrotoxicosis and other forms, and raised 3T3 and 3T4 unless it's a subclinical situation. ESR is useful if you're thinking about potential thyroiditis, but of course ESR is usually normal in Graves' disease and toxic nodular disease, but may be raised in thyroiditis. Thyroglobulin really is a very useful measure here, because if this is low, then that hints towards factitious thyrotoxicosis. There will be no or little uptake on an isotope uptake scan, whereas in Graves' disease you will get diffuse uptake. There'll be patchy uptake in patients with toxic nodular disease, but of course, similar to factitious thyrotoxicosis, in patients with thyroiditis, uptake will be low. There is absent hypervascularity in factitious thyrotoxicosis, and often in thyroiditis, Graves' disease, you will have hypervascularity, or you may see thyroid nodules for toxic nodular disease. A useful test is to measure fecal T4, because T4 should not be present generally in feces. However, I have not been able to find a laboratory in the UK that does this. And you can also do a 24-hour urinary iodine uptake, which will generally be raised if the patient is ingesting a lot of T4 or thyroid hormones, but not in other forms of thyrotoxicosis. So just as a summary, and this is a sort of prelude to my next talk, which I think is in a month's time, about drug-induced hypothyroidism. What I've covered here are a number of cancer drugs. So we talked about immune checkpoint inhibitors, resulting in a number of endocrinopathies. Alemtuzumab Graves' disease is really important. And then thalidomide analogs, again, can cause a thyroiditis, but often will cause hypothyroidism, and I will come back to this. And of course, there are a number of conventional agents that we use in cancer treatments, which will lead to an alteration in binding proteins. Drug-induced thyroiditis, we talked about amiodarone, and we talked about monoclonal antibodies, again, looking at these immune checkpoint inhibitors that can induce thyrotoxicosis and thyroiditis. So just as a summary, I hope I've convinced you that drug-induced thyrotoxicosis is common, whereas drug-induced Graves' disease really is less common. If it's drug-induced thyroiditis, it is often transient, but beware that many forms are a destructive thyroiditis and patients may require long-term levothyroxine. It's important to distinguish type 1 and type 2 AIT because this influences our therapy choices. You need to monitor patients treated with alemtuzumab, and you have to remember that immune checkpoint inhibitors, which increasingly are used in so many different cancers now, often result in thyroid dysfunction, which in most cases is transient. I've also illustrated that factitious thyrotoxicosis is difficult to diagnose and manage. Thank you for your attention.
Many thanks, Dr. Christine Boulard, for such a clear and interesting talk with quite enriched with cases, and thus capturing the ideas becomes much easier. We are almost reaching 400 in terms of attendance, good number. Please, if you have any questions or queries, we're going to answer and respond to it by the end of the talk. Now, at the beginning, I forgot that we'd like to thank Merck for sponsoring this series of thyroid webinars. And our next title of the talk is Novel Treatment Approaches in the Management of Thyroid Eye Disease, and will be delivered by Dr. Mario Solvi. He's the head of the Graves Orbitopathy Center, recognized as the Center of Excellence at the Granda in Milan, Italy. Since 2003, he has pioneered immunotherapy and has been carrying out clinical studies on the use of rituximab, anti-BAF belimumab, and anti-IGF-1 receptor antibodies, the teprotumab, and the interleukin-6 receptor antibody tocilizumab, and Graves' arthropathy. In addition to participating in multi-center trials carried out in the European Union, the European Group of Graves' arthropathy. He was a PI of the Marie Curie FP7 projects Indigo from the years 2014, 2018, studying the relationship between human microbiome and the autoimmunity in Graves' disease and orbitopathy. Welcome, Dr. Mario Solvi, and the floor is yours.
Okay, good afternoon. I thank the organizer for inviting me to present this presentation of the option of treatment of Graves' orbitopathy or thyroid eye disease, as is also called. These are my disclosures. Well, I will start with showing the data that have been, produced in this study, multi-center trial conducted within the UGOGO community, the European Groups on Graves' Orbitopathy, in which we compared the dosing of intravenous steroids and trying to find, was a dose finding study in order to find the optimal treatment for the disease. We're talking about intravenous methylprednisolone, which is considered the first step, the first indication for treatment of active, moderate, severe active eye disease. And as it's shown here, this trial consisted of challenging 3 different doses of steroids. And as you see from this, data, from this figure, you see the clinical activity score, the response based on inflammation at 6 and 12 weeks was very interesting in the sense that more than 80% of patients, both with the intermediate and the high dose, did inactivate disease. Whereas when we go to the overall assessment of the ophthalmic signs of the disease, we see a difference in the sense that about 50% of patients responded, 55% of patients responded well to the high dose, but the intermediate dose only partially. So this also was balanced versus the side effects that were measured throughout the study. And as you see here in this slide, most of severe side effects were occurring when the high dose was used. So as a summary of the study, low dose had minor and later side effect on inflammation, though the problem was that the lower the dose, there were very little effect on eye motility. So as a suggestion for this study was that most cases can be treated with intermediate dose, although high dose should be usually adopted, administered when cases are more severe, patients have more severe disease. A problem with steroids that we know, and this is the typical diphasic curve of the course of the disease, the Randall curve, the active phase, the stable phase, and this is the curve of severity. And then we apply steroids. Maybe we may have a response, but often steroid may relapse or may not respond at all. And this occurs in about 24% of patients. In addition, to have an effect, a significant effect, you have to treat patients very early. And this study shows that there is an inverse relationship between the timing in which we treat patients and the response. So based on this, we did conduct a study in which we did want to see what was the response based on the timing of treatment in this patient. And what we observed was that about 70% of patients treated with IV steroids respond as early as 6-8 weeks, even with a cumulative dose of 4.5 grams, which corresponds to the intermediate dose studied in the UGOGO study, used in the UGOGO study. Only another 10% of patients improved after the continuation of this. And if we study in detail, we see that especially patients who are smokers are the ones responding less. So we devised some sort of a workflow, and then we propose is that we treat patients with steroids with a cumulative dose of 4.5 grams, which is the intermediate dose. We stop at 6 or 8 weeks, and we see if there is a response. If it's positive, it's fine. We can continue on and taper down the steroids. If there's no response, well, if we develop optic neuropathy, that we have to apply a different treatment. Usually, we change the steroid schedule to very high doses of steroids or surgical treatment. The other alternative is to continuing therapy with steroids associated to other immunosuppressants or switch to other new immunosuppressants that have become available lately in clinical practice. And this cartoon shows very well the possibility of interacting with the system. This is actually a cartoon that summarizes a little bit the pathogenesis of this disease. And what we see here that when we're talking about immunosuppressive drugs, we can target different compounds. We can target immune cells, so B and T cells. We can target cytokines, and for example, IL-1, IL-6, or we can target specifically some receptors expressed on the fibroblast of the orbit, namely, especially recent studies have been shown that targeting the IGF-1 receptor, which is coupled to the TSH receptor on the fibroblast, as a possible target of disease. So let's show, I mean, the first immunosuppressant that was tried was rituximab, which is a drug that targets B cells, depletes B cells from the circulation. But the interesting observation that we made was that when we applied rituximab as compared to steroids, we did deplete CD20 cells, so B cells from the orbital tissue, but also from the periphery. From the periphery and also from the orbital tissue, but also we observe depletion of T cells. And this is very interesting because this makes us hypothesize that the effect of rituximab in depleting B cells counteracts the B cell effect, action as presenting cells, not so much the B cell producing immunoglobulins. And I'll get back to that a little later. This randomized control study that we conducted a few years ago showed very clearly that up until the 12th week, when we were applying either steroids or rituximab, the decline of the clinical activity scores was very similar. But when we stopped steroids, the patients on steroids would relapse, whereas patients treated with rituximab were remaining inactive. And just to remind you, rituximab was administered only with 2 dosages at the beginning of the study, and just 1 single dose of 500 milligrams, just 1 shot at the beginning of therapy, whereas methylprednisolone is administered weekly, as I showed in the slides previously presented. We also study the overall improvement by considering the effect on the composite ophthalmic score, considering diplopia, proptosis, and all the other factors besides inactivation. And what is interesting is that if you recall the slide on steroids, that in fact, we did obtain an overall improvement of about 38–40% with steroids, which is what was observed also in the study of Yugogo. With rituximab, the improvement was much, much higher. But what was even more striking was that when we looked at relapses, we know that, as I was mentioning before, patients treated with steroids may relapse, and the relapse rate in this patient was fairly elevated in this study, whereas the relapse rate observed with rituximab was very, very low. And this suggests that perhaps the effect of rituximab is something really that plays a role in the natural course of disease. So it is modifying the course of disease, probably, especially when it's employed very early in the disease. And I say that because a similar study conducted by the American group at the Mayo Clinic of Mario Stan, they did perform a study using rituximab, this time with a control group with placebo control group, and they could not find the efficacy that we showed in our study. And when we put together our data in a post-hoc analysis, what was really striking and amazing was that the major difference between the two populations was that the patients studied in our group had a very short duration of disease, whereas the duration of disease in the patients of the Mayo Clinic was much, much longer. And this may explain why the effect of rituximab is really important when it is employed very early in the disease. Then when we compared the number of smokers, in fact, smokers were much, much more in our group, and that usually smokers are less responsive with whatever immunomodulatory treatment we do, even with steroids. And when we measure TSH receptor antibodies, probably our patients were somewhat less severe than the one studied in the American study, because the levels of TSH receptor antibodies was lower. Well, rituximab is important, though, to know that the effect of rituximab on the depletion of B cells occurs very, very early. Actually, we managed to observe practically no B cell in the circulation after 45 to 60 minutes. And this has led us to conduct a study in which we employed a very low dose of rituximab. We're talking about 100 milligrams of rituximab, one single dose. This is an open study that we just recently published of the thyroid, and what you observed here, that just by the 8th week after treating with one single dose of 100 milligrams of rituximab, about 65% of patients were inactive, and at 12 weeks, about 93% of patients had inactive disease, so had a response to treatment. Well, this depicts very well the expression of CD20 of lymphocytes, as you see. So, and this is the target of rituximab. But we were also interested in studying another molecule, the BAF, the B cell stimulating factor. It's a cytokine that intervenes at the transitional level of the maturation of B cells, and it helps in expanding the clones of production of B cells and antibodies, and this usually happens when the disease is in the active phase. And there is a molecule that we came across that is belimumab. It's an antibody, monoclonal antibody that counteracts the effect of BAF. And this was why, because we had done studies in this population in which we were able to show that serum BAF levels were elevated in patients with Graves' disease, whether or not they had active or inactive disease. And interestingly enough, in subsequent studies, we were also able to show that the BAF, the molecule BAF, and the receptor of BAF were expressed not only on infiltrating lymphocytes as it is expected, because this is a molecule expressed on immune cells, but was also expressed on thyrocytes. And this, in a way, brought us to the idea of trying to target this cytokine with this monoclonal antibody that I said, the belimumab, and we designed a study. We just concluded the study in which we challenged belimumab versus IV methylprednisolone. And again, we looked at the decrease of clinical activity score, safety, and also the secondary endpoints, the effect on the severity signs of disease. And this is the results. As you see, what we observe very nicely is that belimumab does decrease the clinical activity score, so does inactivate disease as well as steroids do, with a little difference at 12 weeks. Steroids seems to be acting earlier, and there is a difference of the clinical activity score at 12 weeks, but at 24 weeks, both drugs act in the same way, with a significant decrease of the clinical activity score to start with. So we believe that this is, we're still studying now the immunology of the study. We're measuring antibodies. We would like to see and try to get more into the insights of how this drug works, but this may represent a good alternative to steroids when they do not work. Another molecule that I wanted to talk to you about is teprotumumab. As I mentioned before, this is a monoclonal antibody that is targeting the IGF-1 receptor. And studies early in the year 2000, the beginning of 2013, 14, 15, conducted mostly by the group of Terry Smith, they have shown that the expression of the IGF-1 and on the fibroblast in some way interacting with the TSH receptor was important in the triggering of adipogenesis. So teprotumumab was made available as a drug, and then actually at the beginning of this year, the FDA approved the use. It's actually the first drug approved for use in thyroid eye disease. And two randomized control studies were conducted, both in the States and in Europe. and they included patients treated with teprotumumab and an arm of patients treated with placebo. And the results were striking because, especially in terms of what was observed with the response in the decrease of proptosis. As you see here, and up to 85% of patients had a significant response, a decrease of proptosis in percentage that was very different to what was observed with placebo. And as well, the change from baseline, as you see, the average change of proptosis was between 2 and 3 millimeters, which is actually something that was never observed before with any other drug. Interestingly, also, on somewhat delayed, there was also a decrease of the clinical activity score, and also a significant response, is about 70% of patients of the overall eye sign response. Interesting, if you see in this image, you know, the effect, this is a CT scan of the patient before and after treatment. You see a significant decrease of the diameter of the eye muscle after treating with teprotumumab. So we're very excited about this. This, unfortunately, is a drug is available only in the United States. It's not available in Europe. It's fairly expensive. And some follow-up studies are now coming out. And you know, the only concern there was that in terms of some side effects that have been reported in a fairly high percentage, consider that in the two populations studied in the trial were about 85 patients all studied. And also one thing that has come out is that a significant proportion of patients had, about 30% of patients had a relapse after one cycle of treatment. And that poses question about the mechanism of the disease and which part of the mechanism of disease this drug is acting on. Lately, there is a study now ongoing in patients, and teprotumumab used in patients with more chronic disease. And I think we're looking forward to the results of this study, because it may well be that this mechanism may be targeted even later on in the duration of disease, and perhaps with less chances of disease relapse in the end. This last drug I want to talk to you about is tocilizumab. Tocilizumab is a monoclonal antibody that binds to soluble and membrane-bound IL-6 receptor, and this cytokine has been shown to be elevated in active Graves' eye disease in some studies in the past. Tocilizumab has been studied in a randomized trial, just in one study so far in Spain, and it was studied versus placebo. And as you see here, the drug was administered for 16 weeks, and the data were analyzed at 16 and at 40 weeks. And as you see, there was a significant response in terms of inactivation of disease that was confirmed also at 40 weeks, although to a lesser extent. And also, interestingly, this drugs seem also to have a very nice effect on proptosis, not as much as teprotumumab, but significantly, about 1.5 millimeters. Here, the details of the study, as you see, the percentage of patients responding in placebo versus tocilizumab, we have about 45% patients at 16 weeks, which decreased later on in terms of eyelid aperture. The effect of inflammation also is elevated, is about 90% of patients responding. Very low response on diplopia. And it's significant, it's interesting that also proptosis seem to be involved in a significant response with this drug. This drug was studied, as I say, in a study versus placebo, and we definitely need to compare this drug versus what is considered first-line treatment, IV steroids. And myself, with some colleagues in Italy, were conducting a multi-center trial in which we are challenging tocilizumab according to the protocol used in the Spanish study versus IV steroids. Right now, we recruited 26 patients. We're expecting the study to finish at the end of 2022, and we're looking forward to confirm the interesting data shown by the Spanish study. A joint force the American Thyroid Association and the European Thyroid Association have joined force and selected a certain group of members who are now working on writing a consensus statement on the treatment of this disease, in view of the fact that right now, first of all, it would be the first evidence-based guidelines or consensus similar across America and Europe, since we have discrepancy about the availability of drugs on the two sides of the ocean. And also what we want to do is besides clinical assessment and criteria for referral, also indication for treatment, especially focusing on medical therapies given the availability of novel treatments. This table we're working on is just slightly summarize some of the data we're putting together of the drugs that I've talked to you about so far, and by analyzing separately the effect on disease inactivation, the improvement in severity signs, and the disease relapse. As you see here, there are some very important differences. I was mentioning before, very low relapse with rituximab, very important effect on proptosis with teprotumumab, and elevated disease inactivation with tocilizumab, with somewhat very interesting reduction in proptosis as well. So all these things has to be put together. And in particular, we also want to give a special indication in particular clinical situation. As you see here, patients who are more at risk of developing optic neuropathy, people resistant to steroid, patients with, with pregnancy, with liver disease, with all possible infection, cardiovascular disease. Let's not forget that many of these immunosuppressants cannot be used in some specific situation, clinical situation. And the drug that we studied are all the drugs that have been studied in various randomized or non-randomized trial. I mean, evidence-based medicine in this field is very limited. So this is the list of the study we're studying. I stop here. I thank the group, my collaborators who have helped and putting together a lot of the data that I presented here and I've been producing over the year. And I'm looking forward to questions in the debate. Thank you.
Thank you so much, Dr. Mario Salvi. Interesting talk, and clearly the evidence is there now to probably move from steroid therapy for orbitopathy to monoclonal antibodies, and over time the evidence is getting stronger and stronger. And we're glad to have new boys in the block for this modality of treatments. Our next speaker is Dr. Kari Kitahara. She's a senior investigator in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute. She has a broad interest in the descriptive epidemiology and etiology of radiosensitive tumors, including thyroid cancer. She serves as the principal investigator of a large cohort study of US radiologic technologists with up to 35 years of follow-up, and a large cohort study of patients with hyperthyroidism who were treated in the US and the UK between the year of 1946 to the year of 1964. Welcome, Dr. Kari, and the title of the talk will be the role and risk of radioactive iodine therapy in thyrotoxicosis. Welcome, the floor is yours.
Hi, my name is Kari Kitahara. I am a cancer epidemiologist and senior investigator in the Division of Cancer Epidemiology and Genetics at the United States National Cancer Institute. And I'm delighted to present to you about the role and risk of cancer associated with radioactive iodine therapy for hyperthyroidism. I have no disclosures. Radioactive iodine has been used in the management of benign and malignant thyroid diseases since the 1940s, and it's one of three main treatment options for patients with Graves' disease. As you can see from this figure, there is substantial geographic variation in terms of physician preference for these three treatment types. with radioactive iodine shown in red being much more commonly preferred historically by North American, especially US physicians, compared to physicians in Europe, Latin America, Asia, Middle East, and elsewhere, where antithyroid drugs are much more commonly preferred as first-line therapy. Surgery in the case of uncomplicated Graves' disease, as you can see, shown in green, is very seldomly considered as first-line therapy, or at least that has been the case in the past. Now, these treatment preferences have shifted over time. So we can see that there's been a decline in the preference toward radioactive iodine therapy in some parts of the world since the early 1990s, and these sorts of trends have continued to this day. And this decline has been in favor of antithyroid medications. One of the reasons why there might have been a decline in radioactive iodine treatment preference may be an increased understanding and awareness of the late effects of radiation exposure more broadly. So we know a lot more about the effects of radiation on cancer today compared to even 20, 30 years ago. Now, radiation is considered one of the most well-studied and well-established causes of cancer, and we know that radiation is a cause of most types of cancer. And following a latency period after exposure of about 5 to 10 years for solid cancers and 2 years for hematopoietic malignancies like leukemia, that the risks tend to increase linearly with dose, as you can see from this figure based on data from the Japanese atomic bomb survivor cohort, which is our gold standard study in radiation epidemiology. We also know that for the same level of radiation exposure, that individuals exposed at young ages have a higher risk than individuals exposed at older ages. So children are particularly vulnerable to the late effects of radiation exposure. And they also live a lot longer, over which some of these late effects can be observed. We also know that these risks of cancer can remain elevated for many decades following exposure, and it's possible that they may never go back down to zero. So based on the totality of evidence from radiobiology and radiation epidemiology, including large cohort studies of populations exposed, like the Japanese atomic bomb survivor cohort, individuals exposed from radiation fallout from Chernobyl and from other environmental contamination, medically exposed populations of patients and occupationally exposed groups of workers, that the risk appears to increase with greater level of dose. And various expert committees have concluded, based on this evidence, that there doesn't appear to be a risk. There doesn't appear to be a level of radiation exposure below which there is no risk. So there doesn't appear to be any safe level of radiation exposure when it comes to cancer. And the smallest dose has the potential to cause a small increase in risk to humans. So when we think about how these data apply to the situation of patients treated with radioactive iodine therapy, we can assume that because radioactive iodine therapy exposes a number of different organs and tissues to radiation other than the thyroid gland, which is the target of the therapy, that there may be at least a small increased risk of cancer at those sites. There have been a number of cohort studies that have attempted to quantify these risks directly. Studies of patients treated for thyroid cancer, which involves higher administered activities post-thyroidectomy, so the thyroid gland is removed in thyroid cancer patients before the radioactive iodine is administered, and in patients with hyperthyroidism who have an intact thyroid. So this affects how much radiation from a given administered dose influences or is absorbed by these other organs and tissues. In any case, for thyroid cancer patients, we tend to see about a 2 to 3-fold increased risk of leukemia, about a 50% fold increased risk of solid cancers, particularly salivary gland, bone, soft tissue cancer, and gastrointestinal cancer. And we also see in some studies, including a couple of recent studies, that the risk of cancer tends to increase with greater administered activity. The data for cancer risks in patients with hyperthyroidism have been much more limited and inconsistent compared to the literature on thyroid cancer. with some studies showing increased risks of some cancers and some not, and some studies showing increased risks with higher administered activity and some have not. I want to emphasize how challenging it is to summarize the literature on this topic and to directly compare the results across these studies in a review, or even more so in a meta-analysis. Trying to come up with some overall estimate of risk is especially difficult because we have to think about all the various sources of confounding in these studies. These are observational studies where patients are receiving one type of therapy or another, and there are a lot of reasons contributing to these decisions. This is very different from a randomized control trial where patients are assigned a treatment, and confounding is not so much of an issue because the treatment assignment is supposed to be random. And these studies are many reasons why someone might choose radioactive iodine therapy, and they could be related to age, sex, socioeconomic status, overall health status, like comorbid conditions, reproductive history or reproductive plans, among other types of potential factors that could also influence the risk of developing or dying of cancer. Also, different comparison groups are used in these studies, which I'll explain is a major issue. And in the interpretation of the results, there's different methods of follow-up, either until diagnosis of the cancer or death from the cancer. Really important are limitations like insufficient length of follow-up, because we're dealing with an exposure that takes many years in order to take effect and can be observed over many decades following that exposure. We need to have studies that have very long periods of follow-up, at least 10 years, preferably much longer than that. We also need very large studies in order to have sufficient statistical power to detect relatively small, modest effects. So many of the studies on this topic have had small numbers of outcomes. They're based on small populations of patients followed for a short period of time. Also, we're dealing with radioactive iodine therapy, which doesn't have a huge range in terms of the level of exposure to the patient. All of these can affect statistical power. Choice of comparison group is really important in this context because most studies on patients with hyperthyroidism have relied on an external or general population comparison group when attempting to quantify cancer risks. So they calculate standardized incidence ratios or standardized mortality ratios, or the number of observed cases or death over the expected number of cases or deaths. There is huge potential for confounding in these sorts of studies because not only are we concerned about the same sources of confounding that I just mentioned, but we're also thinking about all the different ways that patients could differ from the general population. So if, for instance, the disease itself, hyperthyroidism, has some effect on cancer development or cancer survival, this is another major source of confounding that we can't adjust for in those studies. Slightly better is if we compare one patient group versus another patient group, because at least they have the same disease. We don't have to worry about confounding by the disease itself, but we still have to worry about confounding by indication and confounding by other factors that differ for radioactive iodine treated patients and patients treated with drugs or surgery. So a better method to attempt to quantify cancer risks after radioactive iodine therapy is to look at dose response. So here we are comparing patients with the same disease treated using the same type of treatment, here radioactive iodine, just at different levels of dose. So in theory, if radiation treatment, radiotherapy is a cause of the cancer outcome, you would expect that the higher the exposure to that treatment, the higher the risk of the cancer-related outcome. So for these reasons, expert committees who review the scientific evidence on radiation and cancer consider studies evaluating dose response to be of highest priority and to yield the strongest evidence, especially when modeling estimated organ tissue doses. In other words, the exposure that's received at the organ or tissue site where the cancer might arise. So of the major cohort studies evaluating cancer risks in patients treated for hyperthyroidism to date, the only one with estimates of organ tissue dose, and also the one with the largest number of radioactive iodine treated patients and the longest follow-up duration, is the cooperative thyrotoxicosis therapy follow-up study. So this is the study that I'll be focusing on for the remainder of the talk. The CTT-FUS study is a cohort of about 36,000 patients who were treated for hyperthyroidism between the mid-1940s and mid-1960s in one of 25 US or UK centers. Most of these patients had Graves' disease and most were women. And there are various treatment combinations that the patients received in this study. About 2/3 received radioactive iodine therapy either alone or in combination with surgery and or antithyroid medications. About 2/3 received surgery without radioactive iodine, and 4% received only antithyroid drugs. So this is a cohort of mostly middle to older age adults. There were very few children. The median I-131 administered activity was 7.3 millicuries for those with Graves' disease and 13.2 millicuries for those with toxic nodular goiter. And as you might notice, this is a slightly lower level of administered activity than patients would typically receive today, the recommended levels being between 10 and 15 millicuries for Graves' disease. And patients were followed up in the study from the time of entry, which is typically around the time of treatment, until the date of death or loss to follow-up. So a very well-known analysis of these data were published in the late 1990s in JAMA by my former colleague, the late Dr. Elaine Rahn, who was a researcher in my group at NCI. And she led an analysis of the mortality data through 1990, at which point about half the cohort members had already died of some cause. They calculated standardized mortality ratios, or they observed over expected numbers of deaths, which, as I mentioned, this is an external population comparison type of analysis. They looked at these SMRs according to various patient characteristics. They found that overall for these patients, regardless of modality of treatment, that there was a higher than expected rate of lung, kidney, breast, and thyroid cancer related death, and a lower than expected rate for uterine and prostate cancer death. Most of the observed associations were based on data from the first 4 years of follow-up. So what this says is that most of what was observed here in this first bullet point was not a treatment-related effect. It had to do with the underlying disease status of the patients. There were some differences by type of hyperthyroidism, and they attempted to look at the effects of radioactive iodine treatment in isolation. They calculated SMRs for thyroid cancer death and found higher than expected rates, but they did not find a clear pattern in these SMRs by level of administered activity, suggesting that this was not a treatment effect of the radiation therapy. And while they calculated estimates of organ tissue doses from this therapy, they were based on very crude assumptions, and they only looked at dose response for leukemia mortality using red bone marrow dose estimates. Here they found no association. So they concluded that based on these results, I-131 appears to be a safe therapy for hyperthyroidism. So can this be considered a definitive null study on this topic? So the researchers themselves noted that there was limited statistical power in this analysis to quantify some of the cancer-related risks, especially considering the relatively low range of non-thyroid organ and tissue doses that would be expected for patients treated using radioactive iodine. And at the time of this publication, there was a lot less known about risks of cancer at these low levels of dose below 200 or 100 milligray. At the time, it was still uncertain whether there was this threshold or safe level of radiation exposure below which there would be no risk of cancer. We know a lot more about cancer, the association between radiation and cancer today. Moreover, in that analysis, they really relied on these external comparison groups, which are highly susceptible to confounding. either by the disease itself or by treatment indication or other factors that differ by treatment allocation. The organ tissue doses that they did estimate in this study were based on very crude assumptions, and they only looked at red bone marrow dose in leukemia. They did not conduct any formal dose response assessment for solid cancer mortality. So there were still a lot of unanswered questions. So since this earlier publication, and really over the past 10 years, there were some important updates to the cohort. First, we extended the mortality follow-up by 24 years. So this allowed for a lot more cost-specific related deaths to be included in our 2019 and 2020 analyses. And there was also a major dose reconstruction effort led by Dunstana Mello in our group. These results were published in 2015 in Radiation Research. So the dose reconstruction effort was a major improvement over the earlier version in the Ron paper because they used an iodine biokinetic model that was specific to patients with hyperthyroidism and calibrated using radiation measurements to a subset of the patients. They also used state-of-the-art methods for calculating doses, including the use of more anatomically realistic computational voxel phantoms. So you can read more about these methods in this earlier paper. And these were the organ tissue doses that we used in our assessment of dose response. So I'm showing here in this table the range of organ tissue doses following radioactive iodine therapy for hyperthyroidism in this cohort. So as you can see, the thyroid receives a very high dose. Obviously, this is the target of the therapy, median of about 98,000 milligray or 98 gray for a median administered activity of only 8 millicurie. And although this is the target of the therapy, other nearby organs and tissues do receive some level of dose. The esophagus and salivary glands receiving a fairly sizable dose here. Also, you can see the liver, lung, lungs, red bone marrow, stomach, breast, etc. also receive a fairly non-trivial dose because after the radioactive iodine is ingested, the thyroid absorbs it and becomes its own source of radiation exposure in the body. So any nearby organs and tissues are receiving direct gamma radiation from the thyroid. Also, any organs along the digestive tract are receiving some dose because that's the route that the radioactive iodine is taking. And if those organs can concentrate or take up the radiation, then they receive some dose as well. So we sought to estimate the cancer mortality risks associated with radioactive iodine therapy using a more formal dose response assessment than has been done previously in this or in any other cohort study. So we restricted our analysis to the radioactive iodine treated patients, and we excluded anyone with a history of cancer at baseline because they are already at the time of treatment at high risk of dying of cancer. We used the updated mortality follow-up, and we used standard statistical regression analysis to quantify the excess relative risk for site-specific cancer death by level of organ dose. We incorporated a 5-year latency period after last I-131 treatment, which means that we didn't include any deaths or person years in the first 5 years after the treatment because it's very unlikely that those deaths would be related to the radiation exposure itself. And we adjusted for a number of different patient characteristics. So basically, these models estimated the magnitude or the slope of the relationship between risk of mortality for a particular cancer on the y-axis and dose to the relevant organ site on the x-axis. So for the manuscript, we presented the risks per 100 milligray for each of the organ tissue sites. And we did this to allow for more direct comparisons of our results with other radiation exposed populations like the Japanese atomic bomb survivor study that I mentioned, which is our gold standard study in the field. So for this analysis, we used the relevant organ tissue dose. So for instance, breast dose in relationship to breast cancer mortality, lung dose in relationship to lung cancer mortality, and so on. And for all solid cancer mortality, we use stomach dose as an estimate of full body exposure. So shown here are our main results, the relative risks at 100 milligray relevant organ tissue dose by cause of death. And this corresponds to table 3 in our manuscript. So you'll notice that we saw a statistically significant positive association for all solid cancer death combined. So a 6% increase in risk for every 100 milligray stomach dose. And for female breast cancer, we found a 12% increased risk for every 100 milligray breast dose. When we excluded breast cancer from this top category of all solid cancers, we still saw a statistically significant positive association of 5% per 100 milligray stomach dose. So this overall result was not being driven by breast cancer. You can see for these other solid cancer outcomes that the risks were in the positive direction mostly, apart from these outcomes down here that were based on very few deaths. And for leukemia, it was surprising that we saw no association at all, but this was based on only 59 leukemia-related deaths. So these figures show simply that the associations for all solid cancers combined and breast cancer follow this linear dose response pattern. So we saw that regardless of whether we used exposure on a continuous scale, using a spline function, or using categories of exposure in our models. Similarly, when we looked at all solid cancers excluding breast, it followed the same pattern. And this chart shows that the magnitude of our dose response estimates for solid cancer and breast cancer were very much in line with those of other high quality radiation epidemiologic studies, which suggests that our results, at least for these two outcomes, appear to be valid and not driven by some major source of confounding in this cohort. So it's important to mention also that the relative risk at 100 milligray, which is what we showed in our table and our figure, in that figure that I just showed you, is that these results don't translate directly into relative risk for treatment yes versus no. Although those risks can be derived from our model, and we provide that formula in our table footnote. But in the cohort, the median administered activity was about 8 millicurie, which corresponds to about 100 to 150 milligray stomach dose. So the 100 milligray stomach dose is on the very low end of that range. So the relative risk for treatment, yes or no, in the cohort would have been slightly higher than what was shown in that figure. And nowadays, the standard range of administered activity is even higher than that. So it's recommended to use between 10 and 15 millicuries for patients with Graves' disease now, which corresponds to 150 to 250 milligray stomach dose and about 100 to 250 milligray breast dose. You can see there's a range around those estimates. And then that corresponds to, if we really want to estimate the relative risk for treatment, yes or no, based on today's recommended ranges of administered activity, the relative risk would be between 9 and 15% for solid cancer and 12 to 30% for breast cancer. So still, these are fairly modest risks that we're talking about. So to give a more population level or public health perspective on the topic, we estimated that for this more typical range of administered activity of 10 to 15 millicurie, that there would be anywhere between 20 to 30 excess solid cancer deaths over the lifetime of every 1,000 patients treated today at age 40 or 50. And this is based on current mortality rates in the United States. So since baseline cancer mortality rates increase as people get older, they increase with age, most of the excess deaths would occur after the first 20 years following treatment. Only 8% would occur within the first 20 years after treatment. Similarly, for patients treated at age 50, only 25% would occur within the first 20 years. So again, these are fairly modest increases, not only increases in relative risk, but also absolute risk, as you can see here, and they're long-term, they're not short-term increased risks. Immediately following the publication of our 2019 study, there were a number of questions raised about why we did not simply compare cancer risks for patients treated with radioactive iodine versus surgery or drugs. And while it's understandable to want to see the results in this way, since patients and their physicians have to choose between one treatment type and another, We demonstrated in the second complementary study in 2020 the problem with using an unexposed comparison group, especially in this cohort. So basically the concern was that it would introduce bias into our estimates of risk due to uncontrolled confounding by factors that differed between radioactive iodine treated patients and those treated with surgery or drugs. So for instance, the small group of patients treated only with radioactive iodine therapy, which as I mentioned was only 4% of the full cohort, included individuals who were much more likely to have a comorbid condition at the time of study entry than these other groups of patients. They were much more likely to have a history of cancer, cardiovascular disease, diabetes, and other medical conditions. And we also observed some other patterns in the data suggesting that patients treated with surgery tended to be a bit healthier than some of these other groups. So we were concerned that we would not be able to completely adjust away this concern about confounding by indication if we compared these groups head to head. Nonetheless, we show these results in our 2020 paper. You can see that there are no statistically significant differences across these treatment groups, but also that some of these groups, like the surgery-only group and the drug-only group, had a fairly small number of outcomes, especially for breast cancer, so very wide confidence intervals. There are a number of other limitations to trying to understand the risks from some of these other treatment groups. We had very crude information on antithyroid drugs, like what types of drugs were being administered, what dose of drugs. So there were a lot of limitations with comparing these groups directly to each other. Nonetheless, we also show that when we look at the radioactive iodine treated group, that the risks increased with greater administered activity, such that for every 10 millicurie administered activity, there was an 8% increased risk of solid cancer death and a 10% increased risk of breast cancer death. So these results were very much in line with our 2019 dose response estimates based on organ tissue doses. So to summarize, our 2019 study provided some of the strongest direct evidence to date regarding cancer risks following radioactive iodine therapy for hyperthyroidism. And given the biological plausibility, we know that these risks are induced by direct DNA damage. We know a lot about the association between radiation and risk of certain solid cancers, including breast cancer, from other radiation epidemiologic studies. And we can see that our risk estimates are consistent with these studies. It's reasonable to conclude that radioactive iodine therapy results in a modest increased risk of certain cancers, including breast cancer. So these results may help to inform the decision-making process when weighing the risks and benefits of radioactive iodine compared to other available treatment options. So I'll stop there, and I'd like to thank you for your attention, and I'm happy to answer any questions.
Many thanks, Dr. Kari. And due to the lack of time, we'll move on to the next speaker, Dr. Elizabeth Peirce, Professor of Medicine at Boston University School of Medicine in the section of Endocrinology, Diabetes, and Nutrition. She was the 2018-2019 president of the American Thyroid Association. Her research interests include the sufficiency of dietary iodine in the US, thyroid function in pregnancy, the thyroid effects of environmental percolate exposure, and the cardiovascular effects of subclinical thyroid dysfunction. And the focus of the talk will be hyperthyroid in pregnancy. Welcome, Dr. Peirce.
Hi, it's a pleasure to be with you today. I've been asked to discuss the management of hyperthyroidism in women who are in pregnancy or preconception. And I want to start today by discussing the diagnosis of hyperthyroidism in pregnancy. So first, how we should interpret thyroid function tests in pregnant women and how we should determine the etiology when hyperthyroidism is detected in gestation. And then talk about how we manage that hyperthyroidism in pregnancy, in the preconception period, and then also during lactation. So to start with, it's not generally appropriate to use non-pregnancy reference ranges for monitoring thyroid function in pregnant women, because pregnant women have thyroid function that shifts across the course of gestation. And one of the key drivers of that shift in early pregnancy is human chorionic gonadotrophin. So HCG levels rise until about week 10 or 12 of gestation and then start to decline again. And HCG can stimulate the thyroidal TSH receptor. So when those HCG levels are high, they will drive an increase in thyroid hormone. And that increased thyroid hormone will then feed back at the pituitary and hypothalamus and cause a decline in TSH. So in early pregnancy, when those HCG levels are high, TSH is concomitantly a little bit low. And typically, it's just a small shift downward, so that for most assays, a reference range for TSH that can be used in early gestation is a lower limit of about 0.1 and an upper limit of about 4. Now, measurement of peripheral thyroid hormone in pregnancy is challenging, mostly because one of the other major changes in hormone status in pregnant women is the high level of estrogen. High estrogen causes a huge increase in thyroxine binding globulin levels, and those high TBG levels tend to confound our free thyroid hormone assays. So it's been demonstrated that automated assays for free T4 tend to not be very reliable in the pregnancy setting. They tend to not be well harmonized with each other, and they tend to lose the normal inverse association with serum TSH. So one workaround for this is to use, instead of the free T4 assay, older assays that measure total T4, measure an index of binding, and then calculate the free T4 present. So the free T4 index. And this has been demonstrated to be more reliable in the pregnancy setting. However, it's not always available. So this is what I use in my own patients in the pregnancy setting, but I'm aware that around the world, many labs have phased this older assay out, and it is not universally available. Another workaround is to try and use total thyroid hormone as a surrogate for the free thyroid hormone measurements. And we can do that because we know that the changes in TBG and pregnancy are fairly linear and fairly predictable. Thyroxine binding globulin levels start rising about week 7 of gestation. They plateau around week 16. So what you can do for either total T3 or total T4 is to take your non-pregnancy upper limit of normal for your assay, add 5% per week starting at week 7 until week 16, when you'll be at 150% of your non-pregnancy upper limit of normal, and then can use that 150% of non-pregnancy for the rest of gestation. So we don't have a perfect solution for measuring peripheral thyroid hormone, just important when you measure to take into account the limitations of our assays. And important always when we're treating pregnant patients to think about what does and what does not cross the placenta to the fetus. So maternal thyroid hormone crosses, although at relatively low levels. TSH does not. And the antithyroid drugs, as we'll talk about, cross the placenta. They can affect the fetal thyroid in the second half of gestation when the fetal thyroid is functional. And the maternal TSH receptor stimulating antibodies can also affect the fetal thyroid. So when hyperthyroidism presents in the first trimester of pregnancy, we need to think about etiology. In general, outside the pregnancy setting, the most common cause of hyperthyroidism in women of reproductive age is going to be Graves' disease. But in early gestation, the most common cause is actually not Graves' disease, but it's this entity we know as transient gestational thyrotoxicosis. There are certainly other potential causes of hyperthyroidism in pregnancy, but all the others are much less frequent. For example, autonomously functioning thyroid nodules can occur in women of childbearing age, but they're relatively infrequent. So along with the changes in thyroid function that we've talked about that occur with HCG, there also are symptoms of nausea and vomiting, because HCG mediates not just increases in thyroid hormone, but also hyperemesis and really all the nausea that can occur in early pregnancy. And gestational transient thyrotoxicosis is just sort of an exaggeration of the usual physiologic response of the thyroid to HCG. So this occurs in women with probably particularly elevated serum HCG levels as is seen in twin or triplet gestations, or perhaps in women who have particularly sensitive TSH receptors or particularly bioactive HCG. And in these women, we see not just a subtle increase in thyroid function production, thyroid hormone production in early pregnancy, but we see the development of frank hyperthyroidism. This, as the name implies, is transient. It typically normalizes, usually by about 15 weeks gestation, as those HCG levels decline. So women with this gestational transient thyrotoxicosis do not need treatment with antithyroid drug. Most of them do not have severe hyperthyroid symptoms. Most of them are more symptomatic, typically just with the nausea and vomiting. So we treat with antiemetics, with management of dehydration, and with a short course of beta blockers if there are significant hyperthyroid symptoms. So when hyperthyroidism presents in early pregnancy, we need to distinguish between Graves' disease and gestational thyrotoxicosis. And there are several clues we can use to do this. So the first, as I've already discussed, is the presence or absence of nausea and vomiting. It's pretty unusual for gestational thyrotoxicosis not to be accompanied by a fairly significant amount of morning sickness. We can't use radioactive iodine uptake in scans in pregnancy. That's contraindicated. When stigmata of Graves' disease are present, that's very helpful clinically. So, look for a diffuse goiter or a thyroid bruit or presence of Graves' eye disease. Something else that can be helpful is the ratio of T3 to T4. So often women with Graves' disease are preferentially T3 toxic, and T3 to T4 ratios will be elevated, whereas the opposite tends to be true in gestational thyrotoxicosis, where the nausea and vomiting essentially tends to trigger some of the changes in thyroid function we typically see in starvation, and T3 levels are relatively low. The gold standard, though, probably is looking for the presence or absence of the TSH receptor stimulating antibodies. Those assays are now widely available, and they've become highly sensitive and specific. So once we have determined that hyperthyroidism is present in pregnancy and have a sense of etiology, we need to think about management. And the first issue when Graves' disease is present is to determine whether the associated hyperthyroidism is overt versus just subclinical. Subclinical being defined as we do outside pregnancy as a low TSH, but with normal peripheral thyroid hormone. Subclinical hyperthyroidism, we think from large cohort studies like this one, is not associated with any adverse obstetric complications. So this is a situation where we can just monitor thyroid function without treatment. But overt hyperthyroidism from Graves' disease is different. And we know if that is not controlled in pregnancy, there's increased risk for intrauterine growth restriction of the fetus, for preeclampsia, for preterm delivery. There's higher risk for pregnancy loss or stillbirth. There have been cases reported of maternal congestive heart failure and of thyroid storm, particularly around the time of delivery. So this is a very worrisome situation, and always overt hyperthyroidism in pregnancy does require therapy. So the trick is how to treat it, and this is a little bit challenging. We have known from the 1970s that methimazole is associated with birth defects. It tends to be associated either with aplasia cutis, which is sort of an absence of a patch of scalp on the head, or with disorders of the GI tract. And the PTU-associated birth defects tend to be fairly significant and potentially life-threatening. We thought, until almost a decade ago, that exposure to PTU in the first trimester was safe. But that was sort of upended by this Danish registry study published in 2013 that demonstrated for the first time that it's not just methimazole that can cause birth defects, but that PTU can do this too. It causes different birth defects, typically either disruption of development of the urogenital tract in the male fetus or abnormal cystic structures of the face and head. And the PTU-associated birth defects are typically less severe and less frequent than the methimazole-associated birth defects, but usually are severe enough that children will ultimately require surgical correction. So now we're in a situation where we know that in early pregnancy, it is unsafe to leave overt hyperthyroidism uncontrolled, but that the antithyroid drugs confer some risk. Now, subsequent to the Danish study, we have more recent data from Korea, an even larger registry study, here looking at almost 3 million mother-child pairs. And this Korean registry study demonstrated the same types of birth defects associated with PTU and methimazole as had been seen in the earlier one from Denmark. It did show a slightly lower incidence of these birth defects. So in this Korean study, the risk seemed to be about 9 in 1,000 live births to women taking PTU will have a birth defect that seems to be associated. With methimazole, it's higher. It's 17 in 1,000 live births. And unfortunately, in this study, women who were exposed to both antithyroid drugs in the first trimester seem to have children at risk for both sets of defects. So we don't have an unequivocally safe antithyroid drug that can be used in the first trimester. And that has led to a shift in emphasis to sort of more consideration of other forms of treatment, of definitive therapy with radioactive iodine or thyroidectomy when women have Graves' disease, which is diagnosed preconception. And I think it's important to have a fairly nuanced conversation in any patient who is a woman of childbearing age who might at some point become pregnant, because it is good to have a discussion about preferences and risks and benefits of these various approaches and to have a game plan in place before pregnancy occurs. So advantages of radioactive iodine or thyroidectomy for these patients are really primarily that there's not going to be any need for antithyroid drug exposure in pregnancy, so we don't have to worry about those birth defects. And we know very well how to dose levothyroxine safely and to monitor it effectively in the pregnancy setting. But not every patient wants to have definitive therapy. Not every patient wants to have to be on lifelong thyroid hormone replacement. In addition, there's some disadvantages of definitive therapy that we know well. Certainly, radioactive iodine doesn't always work the first time. It can worsen Graves' eye disease. After thyroidectomy, complications are relatively rare, but some patients have lifelong hypoparathyroidism, which is particularly challenging to manage in the pregnancy setting. And so this is not one size fits all. In women who want to continue on antithyroid drugs, if they're actively trying to conceive, it probably makes sense to switch them from methimazole to PTU, because if there's going to be antithyroid drug exposure in the first trimester, the PTU is going to be safer. In thinking about these options, one needs to think also about timing, that after thyroidectomy or radioactive iodine, typically recommend waiting until women are stable on replacement thyroid hormone before trying to conceive. For radioactive iodine, we specifically recommend against becoming pregnant within 6 months after treatment. So in women who are older or who have concerns about fertility, they may not desire waiting a long time, and those options may be unattractive. We also need to think about the effects of all three treatment modalities on the TSH receptor antibody stimulating titers. So after initiation of antithyroid drugs or after total thyroidectomy, there is a decline in those antibody titers that occurs really right away, and levels tend to be fairly low, often by a year or two after treatment. After radioactive iodine, though, there's an increase in those TSH receptor stimulating antibody titers above baseline, and those levels tend to remain above baseline for about a year. They do decline, but levels tend not to decline as much as they do with the other treatment modalities. And again, those TSH receptor stimulating antibodies can affect the fetal thyroid. So we need to think about this also in our patient counseling. Consider antithyroid drug discontinuation as soon as pregnancy is confirmed. This is a strategy that is suggested in the ATA guidelines, but importantly is not validated in any prospective studies. This is not for all comers. So this is not saying that all patients can stop antithyroid drugs as soon as they're pregnant, but patients who we think are essentially still on antithyroid drug but already in remission are patients to consider for this approach. So these would be women who do not have a big goiter, who do not have a high TSH receptor antibody titer, and who are fully euthyroid with normal TSH on low dose methimazole or PTU. In those patients, they can be instructed to check for home pregnancy tests as soon as a period is missed, as soon as they know they're pregnant, to stop the antithyroid drug and to follow up very closely with initial thyroid function monitoring every week or two in order to determine whether hyperthyroidism has recurred. And the idea here is that we know that many women who have recurrence of hyperthyroidism after antithyroid drug stops, it doesn't happen right away. There's often a several-week delay before the hyperthyroidism comes back. And so the idea is that even if it's going to recur, we may buy enough time with this strategy so that we don't have to restart antithyroid drug until the second trimester when we are no longer worried about risk for birth defects. So again, carefully selected patients can consider the strategy, but this is not for all patients, and this does require close monitoring and resumption of antithyroid drug if hyperthyroidism comes back. More typically, in patients who stay on antithyroid drug, we're going to continue that with close monitoring, typically every 4 to 6 weeks. And PTU is preferred in early gestation if one of these drugs is needed. What we don't know is whether it makes sense to shift back from PTU to methimazole after organogenesis is complete. The argument for doing this is that we know that PTU is associated with rare cases of fulminant hepatic failure. And of course, although these are rare, they are devastating. And cases have been reported in pregnant women on PTU. So the advantage of switching back from PTU to methimazole is that we lower the risk of liver failure. On the other hand, there's not one-to-one dosing congruence. So that when we're shifting, there's the possibility that we will cause a slight period of hyper or hypothyroidism as we're making this transition, and that could have deleterious effects on mother and baby. So we don't know whether shifting back after the first trimester makes sense. I do it in my own practice if for no other reason than I think it's just easier to take a once-a-day drug, but we don't have definitive answers as to which the safer approach is. Now, always in using antithyroid drug therapy in pregnant women, we need to take into account the fact that those antithyroid drugs seem to have a more potent effect on the fetal thyroid than on the maternal thyroid. And if we treat a pregnant woman so that her thyroid hormone levels are solidly in the middle of the normal range, we are probably overtreating the fetus, and there's a risk for fetal hyperthyroidism. So the recommendation, therefore, is to use the absolute lowest dose of antithyroid drug, either PTU or methimazole, that we can get away with, and that is the dose that will keep the maternal free T4 either at or perhaps just above the upper limit of the normal range. Now, the fetal thyroid in the second half of gestation can be affected both by the maternal antithyroid drug and from the maternal antibodies, and it's hard to know what the balance of those two things is crossing the placenta. We do not like to directly measure the fetal thyroid function. Absolutely essential because doing corticocentesis confers a non-zero risk for fetal loss. So instead, we tend to use indirect clues. We can look for fetal size on ultrasound, and ultrasound typically done by our colleagues in maternal fetal medicine, because goiter can be associated with either fetal hyper or hypothyroidism. We can look for delayed or advanced maternal fetal bone age, or we can look for persistent fetal tachycardia, which can be a sign of fetal Graves' disease. We can also use the maternal antibody titers as a clue to what the fetus is likely to be seeing. And it's important always not to forget patients like this. So you can see from her scar that she had thyroidectomy. You can see from her eyes that it was a thyroidectomy for Graves' disease. And this was her infant who was born with goiter shown here from neonatal Graves' disease. So remember, as we've discussed, that patients with those antibodies from Graves' disease, those antibodies can persist after definitive therapy. And so patients who need testing for antibody titers in pregnancy are those women with known active hyperthyroidism from Graves' disease who are on an antithyroid drug, or women who've had a history of Graves' disease that has been previously treated with thyroidectomy or radioactive iodine. And in those women, we should first assess the antibody titers at the first antenatal visit. If they are low, and low is anything less than 3 times the upper limit of normal, we don't need to worry, and we don't need to repeat the testing in pregnancy because those antibody titers are going to decline as pregnancy progresses, and if they start low, they're going to stay low. But when they're high in early pregnancy, this testing should be repeated at 18 to 22 weeks gestation, because that's the time point when the fetus starts to be at risk for having fetal hyperthyroidism. And again, a level more than 3 times the upper limit of normal should cause us to alert maternal fetal medicine to follow that fetal thyroid status more closely. We then would repeat the testing yet again at 30 to 34 weeks gestation, because if the titers remain high at that time point, there's risk for neonatal Graves' disease, and the neonatologist should be alerted about a baby who's going to need closer follow-up. Now, following delivery, we can use antithyroid drugs safely in lactation. We know that both antithyroid drugs are excreted in breast milk, PTU less so than the methimazole, but the doses that are communicated to the breastfed infant are so low that they are not pharmacologic doses. They are not going to change thyroid function. And in fact, in several small case series, it's been seen that there really does not appear to be any adverse effect on the child's thyroid function, or in one small study on the child's intellectual development later in life. So we think these are safe in lactation, but always at the lowest dose that's appropriate. And it's because the data we have for safety in lactation come from very small case series, it's thought to be safest to restrict use of methimazole to doses of up to 20 milligrams a day and PTU up to 450 milligrams a day. Children who are breastfed by women who are taking these medications do not need thyroid function monitoring. It's thought that just the normal pediatric routine health exams looking for appropriate growth and development should suffice. So I would conclude by noting that in pregnant women, we need to use pregnancy-specific reference ranges, and we need to interpret their thyroid function testing appropriately during gestation to make our diagnosis of hyperthyroidism in the first place. That when hyperthyroidism occurs in early gestation, we typically are trying to differentiate between Graves' disease and gestational transient thyrotoxicosis as the likely causes, and we're going to treat those entities differently. That for any woman of reproductive age who has known Graves' disease, we should be making decisions about the preferred choices for therapy in any future pregnancies, ideally before women become pregnant, so that there's a game plan in place. And that always, in treating these patients, we need to consider both the maternal and the fetal effects of any therapies we employ. So with that, I will thank you for your attention.
Thank you so much, Dr. Pierce. Many thanks to all the speakers. Over the last 2 hours and a half, we had wonderful talks covering important topics. And now it came to the most important part, which is the discussion part of it. There are a number of questions that we need to go through, and I'm going to run them. I probably will not finish them all, but we'll try to cover the majority of these questions. I'm glad to see very good response, many questions, and quite active interaction here. Right, let's start with the first question here. What about the role of the interleukin-6 on the thyroiditis? What is the mode of action? This question.
Is that to me?
Yes, please.
Hi, so thank you. Yeah, so interleukin-6 is an inflammatory cytokine that balances pro and anti-inflammatory effects. It's definitely increased in thyroiditis, and with COVID-19, we've seen quite a bit of the role of interleukin-6 in patients who are going to develop thyroid dysfunction. It's implicated in both the pathogenesis of Graves' disease and Hashimoto thyroiditis, and we know that in patients with HIV, increased serum levels of interleukin-6 may predict those that will go on to develop thyroid dysfunction. So an important marker to measure in certain conditions, but not something that we routinely measure when diagnosing patients. So I think both Salman and myself have illustrated other ways of distinguishing between the different types of thyrotoxicosis.
Clear. Thank you so much, Christine. Now the other question here. I have a patient with a Graves arthropathy. That's the question probably for Dr. Mario. I have a patient with active mild grave arthropathy, euthyroid off treatment for the last 2 years. I tried selenium and oral steroid, but has relapsed and refused to take a course of steroids. What will be the next option?
Well, thank you for the question. It all depends on the stage of the disease. I think it's important to realize that if the disease is really still in the active phase, even if it's in the mild form, it's a short course of steroids may help in controlling the symptoms. But if you've already given steroids and the disease is inactive, at that point, there's no point in giving any more immunosuppressant. So I think it's very important sometimes in the later part of the course of disease, as sometimes symptoms and signs that are objective signs of the eye signs can be misleading, because sometimes you may interpret as active signs of activity or active inflammation, signs that are instead of congestive disease, which is actually the later form of disease. I think with the help of an ophthalmologist who can rule that out and maybe decide for what perhaps some surgical treatment to follow up this patient better.
Thank you. And that's really to the second question, which is what is the recommended dose of prednisolone for prevention of mild active arthropathy before giving radioactive iodine treatment? When to start and for how long?
Yeah, okay. There have been studies on this, and actually we also published some data on that. And what we do, usually we suggest to start the steroid prophylaxis 48 hours after administering radioactive iodine, because we've observed that that is not going to change the kinetics of steroids the kinetics of the radioiodine when you give steroids. Then you may decide to go with what is considered the full dosage. Usually we start off with 15 milligrams of prednisone, which you taper down in about 8 to 10 weeks. But if the patient has very mild form of disease or inactive disease, you can even elect to choose a lower dose and start off perhaps with only 37.5 milligrams, taper down in 6 to 7 weeks. And it all depends on, how you consider the risk factors of the eye disease before treating the patient. I think it's very important that you look at all of those, besides running a complete ophthalmological examination to see if there is any sign that is suggesting perhaps subclinical ophthalmopathy.
Okay, so you're going to start with a dose of severe cases like 50 milligram prednisolone.
Yes.
And the milder one probably lower to 30 or even 20?
Yeah, we actually half the dose every second week to stop the dose after about 8 weeks.
8 weeks, okay, thank you. Next question is, what the new approach for treating hypothyroidism? Well, we'll skip this question. There will be a separate webinar on hypothyroidism on the 26th of November. So just watch the space. The other question, can radioactive iodine therapy be prescribed for patients under the age of 16? What are specific radioactive iodine side effects in children and adolescents compared with the adults? Probably that's the best question for Dr. Carey.
So I can only speak on the role of cancer, the risks of cancer associated with this therapy. And it is used for individuals under the age of 16. And there aren't any studies directly evaluating these risks in these very young patients, but it would be expected based on what we know about radiation and its effects on cancer development, that the risks should be much higher for a given unit of dose for children compared to adults. So I would expect that if there were such a study that could directly evaluate these risks, that the risks would be higher in this population compared to what we saw in our study of mostly middle to older age adults.
Clinically, we try to avoid, but in some patients who Graves' disease is active for long, we are forced to give them radioactive iodine or to opt for surgery. Now, there's another question. Radioactive iodine treatment seem to have more risk, especially cancer, than antithyroid medication potential adverse effects. Should we reconsider the use of antithyroid drugs rather than radioactive iodine treatment? Also, what do you tell your patients about the risk when discussing the options of treatment? Who would take this question?
I can say a little bit about this. I'm not a physician, I'm an epidemiologist. So I appreciate that these conversations can be very complicated and complex, and that each of the three main treatment options for Graves' disease have benefits as well as risks. So I would support that any treatment-related decision is a conversation between physicians and their patients, and that all of the various benefits and risks are laid out and compared side by side. So what are the risks from antithyroid medications, radioactive iodine and surgery versus what are the benefits? And for a particular patient, this balance of risk and benefits may be different. It may be different for younger patients versus older patients, patients with certain underlying chronic conditions versus more healthier patients. But I think all of these things are important to discuss before deciding on the treatment option.
Okay. Would you like to add anything extra, Dr. Razvi?
You're muted.
Sorry. Yeah. So we do need to have those conversations with patients, and I think it's important that we put all the options in front of them. The issue with cancer in relation to radioiodine has been debated for a long time, but it's only very recent that we have been getting more data on this. And I think it's important that we have a fairly clear conversation that there is a risk, but it's yet to be absolutely quantified in the mechanisms and at what age does the risk really come through. And I suppose the risk would be very different depending on individual circumstances. We also have to weigh up the fact that for some patients, not treating their hyperthyroidism with radioactive iodine might be more immediately dangerous than a potential risk 15, 20 years down the line. So I think a lot of these circumstances have to be taken into consideration.
Definitely, that's clear. Thank you. Another question. On stopping antithyroid medications after 12 to 18 months, would you decide that based on the antibodies on the level of the thyroid function test, basically TRAB antibodies, will it guide you to stop or not? Maybe Dr. Razvi will be the potential.
Yes, so I think if somebody is on antithyroid drugs and we are measuring their TRABs, and it is has become my practice now to do that. And what we find is that people who initially have very high TRAB antibodies are unlikely to have low normal levels at 12 to 18 months, but occasionally it does happen. So in these people, I think it's worthwhile considering a trial of treatment. We do know, however, that there are certain risk groups, for example, smokers and so on, and certain other factors that are probably not taken into consideration as much, such as stress. And stress is increasingly recognized as a big player in the development of the TRABs and the risk of Graves' disease. So I think measuring TRAB at the end has certainly become part of my clinical practice. And once the levels are low, it's worthwhile stopping treatment to give the patient a chance to be able to come off treatment altogether.
Thank you. And this question to Dr. Pierce. In pregnancy, switching from methimazole to PTU, how do you dose?
And of course, you asked me the question that I can't think of off the top of my head because I use PTU so infrequently these days. I have to look this up. One of my colleagues may be able to jump in. It's either 1 to 20 or 1 to 30, but I can't remember off the top of my head.
The conversion is 1 to 20.
Thank you.
Thank you so much. And gestational thyrotoxicosis, need to treat?
No, so we just need to monitor that. That's going to get better as HCG comes down, and almost always by about week 16 of pregnancy, the thyrotoxicosis is largely resolved. So what may need to be done for treatment, most women are mostly symptomatic with that, with nausea and vomiting, but if they do truly have symptoms of thyrotoxicosis, it's reasonable to give a short course of a beta blocker that's safe in gestation, like labetalol, for example, and to provide supportive care, antiemetics, IV hydration where needed. But typically, we like to avoid anti-thyroid drugs where we can, and knowing that the hyperthyroidism is going to be fairly short-lived, it's typically recommended not to use them in that setting.
Thank you. Very clear answer. Do you think that stopping antithyroid medication before pregnancy is a good option, bearing in mind that the congenital defects of PTU are really very rare and does not justify the risk?
So this is going to be a decision that needs to be very much individualized. This is not one size fits all. So it depends. I wouldn't stop anti-thyroid drug if a woman's still hyperthyroid and needs it, because we know overt hyperthyroidism is quite dangerous in pregnancy. So you wouldn't want to risk that. And, deciding between definitive therapy or continued anti-thyroid drug in somebody who needs treatment of some kind, again, different people have different preferences driven in part by severity of hyperthyroidism, about, reluctance to be on lifelong thyroid hormone replacement. And so I think it's like the decision about radioactive iodine versus anti-thyroid drug versus surgery outside the pregnancy setting or outside the preconception setting, that you really sort of need to put everything on the table and have a pretty complete discussion.
Thank you. And this one, the question here, what's the maximum dose of PTU in pregnancy? Is there any maximum dose?
There isn't a maximum dose. The dose that you need is the dose that keeps the maternal free T4, at or just above the upper limit of normal. So there's not a dose that's been shown to be unsafe in pregnancy, as long as you're not overtreating both mother and fetus.
Okay. Then we're moving to how can radioactive iodine treatment increase Graves or petopathy in uncorrected hypothyroidism? I think probably this will answer it in November. Or you want to go for it, Dr. Mario?
Well, yeah, I can answer that. If I got the question correctly, the question is, how does radioactive iodine treatment activates or induces de novo Graves or petopathy? Is that the question?
Yeah, in a patient who is hypothyroid.
Well, okay, hypothyroidism per se is a cause of increasing chances of having a more severe ophthalmopathy. The compensated thyroid, whether it's a hyperthyroidism or hypothyroidism, we all know are really increasing the risk of getting the eye disease worse. And hypothyroidism has been studied as one of these possible causes. In fact, one of the risks is that you may have activation of the eye disease when the patient becomes rapidly hypothyroid after radioactive iodine, and it's not being corrected, and the situation is not quickly corrected. So I think that is to be monitored very quickly. If you administer radioactive iodine, even if you do perform steroid prophylaxis in this patient, I think it's correct. Usually what we do, we monitor thyroid function every 6 weeks, which makes sense. And that is a good way to see if the patient is switching already to hypothyroidism, at that point you start correcting it. Some colleagues, some British colleagues, for example, they choose to administer thyroxine right away after treatment just to avoid this phase. We do not trust doing that because we don't want to have the risk of uncontrolled thyrotoxicosis, which often in our patient occurs in the first few weeks after radioiodine, but we closely monitor patients in order to avoid that.
Thank you. In the era of COVID-19, now what about the effect of increasing inflammatory markers in COVID-19 on thyrotoxicosis ophthalmopathy? Dr. Maria, once again.
Okay, so we have had the chance to see patients, follow patients through I live in Milan, which was really very hardly hit by the pandemic. And we had the chance to follow patients with active eye disease, even during treatment with eye disease. And we also have had patients who reported activation of the eye disease right after having been infected with COVID. And even now we're observing some patients developing or actually activating Graves' hyperthyroidism and even ophthalmopathy more rarely after the COVID vaccine. Well, the situation is during the COVID pandemic, we were very careful at first not to avoid to administer patients immunosuppressants until we actually came to know that steroids were actually the best way to control these situations. So we actually, what we did follow patients during the pandemic, and those patients who were already being treated with immunosuppressant, we just closely monitored them where we did not stop the medication.
Thank you.
Yeah. And as far as the what we are observing now of activation of hyperthyroidism, but even sometimes of eye disease after the COVID vaccine, we believe that that is due to the adjuvant that are usually administered together with the vaccine proteins. It's not the vaccine per se. And there have been reports coming out in the literature lately. And but you know, this patient we really treat the same way as we treat all the other patients. We do not have any special approach for these patients. We don't believe we need to have it.
Yeah, wishing that COVID-19 era will be over. So
hopefully.
There's a question here. What about the role of the retrobulbar steroid injection in a patient with Graves' eye disease?
Well, it's hard to know. There's no evidence, but there are no really evidence-based studies that justify the use of that. Some specialists, some ophthalmologists have been using it. Apparently, the response in some patients is good, but even in the preparation of the guidelines for this disease, we were not able really to trace any major study or control study that justifies the use of that vis-a-vis versus the use of IV methylprednisolone, which is actually the first step in this treatment in this disease.
Thank you. Question for Dr. Pearson here. This is from real life. There are in private hospital, there are some physicians treating high titer thyroid antibodies in a patient who is euthyroid with a steroid, especially pregnant women. Is it justifiable to treat high titer TPO antibodies in a euthyroid pregnant lady?
I think the answer is no. There are two small randomized clinical trials that did show a benefit of that approach in the preconception period, one for women who underwent in vitro fertilization and the other for women who underwent intrauterine insemination. And in both of those very small trials, there was benefit. This has not been studied in larger groups. This has not necessarily been studied well throughout pregnancy. We know that short courses of glucocorticoids are reasonably safe in pregnancy. We don't have a ton of data for the safety of doing that throughout entire gestation, and not really good benefit, evidence for benefit right now. So the ATA guidelines currently actually recommend specifically against that approach, but I think it's an area that probably needs more study.
Right. Question to Dr. Razvi regarding thyroiditis and thyrotoxicosis, for how long it may last?
Thank you. Well, generally the data suggests that thyroiditis causing thyrotoxicosis would last about approximately 3 months, at the most 6 months. If it lasts beyond 6 months, I think we have to revisit the initial diagnosis and recheck the investigations again.
Yeah. We've seen patients with COVID-19 induced thyroiditis, and we've seen patients with COVID-19 vaccination induced thyroiditis. And some of them, they're lasting more than like 3 to 4 months or 5 months even. Yeah. Well, what about your side?
I think that's right. So there is data on the literature. The problem one of the problems is we haven't systematically been looking at these effects in the patients here. We are waiting for people to present with symptoms or opportunistically have thyroid functions checked. I'm not sure, maybe some of my colleagues might know, whether there is any systematic evaluation of the prevalence of thyroiditis post. I know there are case reports, but post-vaccination or post COVID-19, I think there is more for COVID-19 than it is for vaccine-induced thyroiditis.
As far as I know, there is no systematic evaluation. I mean, obviously, the COVID-19 literature changes on a weekly basis. We didn't think that this was going to lead to an increase in Graves' disease, but it does. It's clear, and you can probably understand that pathophysiologically. The thyroiditis that I've seen generally is limited to 6 months or less. It does tend to be quite resistant, as in persistent. And I have certainly used steroids for a number of the thyroiditis where I usually don't actually give steroids, but with the COVID-19 thyroiditis, I have used steroids successfully.
Interesting. That's good. Dr. Pierce, question about giving the radioactive iodine dose for hyperthyroidism during pregnancy.
Never. Absolutely not. So that's contraindicated. You run the risk in the second half of gestation once the fetal thyroid is functioning of destroying the fetal thyroid, never a good thing to do. And there are risks of just the radiation exposure to the fetus. There are good data in the literature looking specifically at risks to pregnancy and of birth defects if radioactive iodine for thyroid cancer is given within 6 months after a radioactive iodine dose, and risks seem to go up. So it has to be at least 6 months after, and also important to note that you should not give radioactive iodine during lactation.
Thank you, that's clear. Dr. Razvi, question. Patient who's switching from hypothyroidism to thyrotoxicosis. Actually, I've seen a patient in my clinic a week ago. She was hypothyroid for probably 1.5 years, and then she went from hypothyroidism to hyper. Do you see these cases?
Yes, you're right. I think with the advent of more precise autoantibody testing, we are now becoming aware of these patients. It's unclear whether they had Hashimoto's disease previously, and then they have now developed Graves, or whether they actually had Graves' disease right from the outset with blocking TSH receptor antibodies. It is recognized in the literature that there are certain factors that can help switch from more blocking to stimulatory antibodies, and levothyroxine use has been suggested as one of these factors. So it is possible that people present with more blocking antibodies as hypothyroidism are treated with levothyroxine, and the use of levothyroxine then triggers the switch to more stimulatory antibodies leading to the thyrotoxicosis. And similarly, it's also possible, and I've seen this quite a number of times, that even after a very short duration of antithyroid drugs, the patient becomes profoundly hypothyroid, and that's with very high titers of TRAB or TSH receptor antibody, and it's likely that it's the switch from the stimulatory to the more blocking antibodies. The problem is that most commercially available assays do not differentiate the stimulatory with the blocking, and we have to run thyroid function and the clinical picture to be able to do that. George Kahali's group has access to those assays, but those are not widely available in other places.
Okay, thank you.
So,
I would pick one. Yes, carry on.
As I said when I talked about alemtuzumab, because in alemtuzumab treated patients, you often see that swinging between hypo and hyperthyroidism, and that is thought to be due to blocking and stimulating antibodies. I think TBI and TSI assays are much more available in the US than certainly in the UK. If we need to know whether they're blocking or stimulating, we need to send them to George Kahali. There isn't a single center in the UK that does it, but we do see it, and I see it actually more frequently post-COVID. This swapping. So it's anecdotal, but I definitely see much more Graves' disease, and I see much more of this swinging.
Thank you so much for cycling. We'll take one last question here. We have more questions to go through, but we have time limit. And the last question, when you see a patient with high free T3 in a thyrotoxic patients, would you think more of Graves' disease rather than thyroiditis? Is not the typical case? Christine? The question is not that clear, but when you see a patient with high free T3 in a thyrotoxic patients, would you think more of Graves' disease rather than thyroiditis?
I probably would, yeah. So, I mean, generally, so a singularly raised T3 quite often is due to a T3 toxic nodule. But if this is early on in the disease state, then certainly my patients who relapse from Graves' disease, it's usually the free T3 that goes up first. So when we monitor them, it's the free T3 that goes up. So I think that would probably make me more think about Graves' disease than thyroiditis, but it could of course be a T3 toxic nodule. And so, that's why you need to evaluate that.
With that, thank you so much. And I would like to thank the audience who continue until the last minute with us. Regarding the CME hours, this activity is entitled for 2.5 CME hours. You're going to receive a questionnaire. So your feedback is very important to improve such activities. And I would like to thank our sponsor for the event, Merck, for sponsoring the thyroid webinar series. And this episode, along with the previous episodes, are available at the Emirates Diabetes Society and Endocrine Institute. And it's available at the YouTube as well. And not to forget, we have a series of young leaders forums, which discuss common endocrine disorders. And the coming one will be on the 15th of December, 2021, and we'll be focusing on endocrinology in women. The series of events coming on the way, including hypothyroidism on the 26th of November, 2021. So please mark your calendar for such event. Not to forget, our annual Congress event will be coming by end of February next year. So please mark your calendar from the 24th to the 26th of February. We don't know yet, could be on site, could be virtual, but we're going to watch the space with the events going on with the COVID-19. With that, I would like to thank you, and my apology that we are not able to answer all the questions. I hope you enjoy this webinar and it has been useful scientifically in applicable scientific and clinical setting. Many thanks to the speakers for your time, for your efforts, and for the clear, nice talks. Thank you so much. Thank you.